minute.
How many members are here?
It's at least 6, I can see. Is that right?
Oh dear.
Slow filling up, but we got
And
5 minutes, I think.
Catherine is not a member of, so that's 5.
In attendance. I think Richard Westwood along as well in attendance. I've given him a couple of questions as well. So from Hannah, as
that's all right. So do you know? So should we all have 1 or 2 questions? Because obviously there's a stupid amount of questions that can be asked at the moment. How would you like to focus this?
I think it'll depend on what Robert Woolley wants to do on his piece. We'll call him in first because he's obviously not on the agenda per se. Because it was
hang on a second. I'll message them. And hang on a second.
Is
Hello,
now joining.
Richard?
Catherine. Yes.
Ian is trying to join to observe, and he's been unable to do so. I don't know quite why. If someone could send him a link, perhaps, to Councillor Parker, if Leo is there.
Leo or Mike Riggle. I think Mike's listening.
Does he want to just use the YouTube then, or does he want to speak and observe?
Either way, we're just here to observe.
Because that's in the notes for the meeting.
Ask questions.
Yeah. I think he wants to join the Teams meeting.
That's in the notes. Oh, YouTube is working.
Parker, didn't it?
Eh?
Was that you, Ian?
Oh no, that was the YouTube feed going. It's about 5 seconds behind us right now.
Is Councillor Willis on phone?
Yes, I am.
Ah, wonderful. It's Ruthie. It's all right.
Hello, love. Yeah, I am on
Hello,
the phone waiting to be admitted.
Yeah, okay, dear.
Excellent.
Oh dear, oh dear.
New times for us all, isn't it, really?
Keep smiling.
Yeah, that's the thing, isn't it? As best you can.
I am smiling, but you can't see me. I'm on the phone.
Yeah.
I saw the email to you yesterday, Ros. So you got a lot of 4G problems up at Wirlbury, Ashby Drive there, haven't you?
Yeah, there is, and they've been working for months down below. Keep popping up OpenReach, but they said there's something out in the road now. So I had phone trouble on my landline in February. There was water on the line. They had to take out something or other. Oh dear. So they think that's what it is now. So until they've sorted that out, I can't sort out whether my iPad is working or not.
I have similar problems, Ros. I mean, it's a nightmare, the broadband for me.
It is a nightmare.
Yeah. I just like a pigeon, really. I'd like a pigeon. I'll put a little note on his leg and send him off. It'd be a lot quicker.
I know.
Maybe we could all do that.
Yes. We could have a North Somerset Pigeon Fanciers Club.
Yes.
Printing's been my problem. I had to handwrite all my notes last night.
Yeah.
Dear God.
I did the same thing.
That's the trouble, isn't it?
Back to school it was.
Got a printer arriving from the post in 2 hours.
Yeah, because if you're on the iPad and doing it and you haven't got a laptop, you can't see the agenda.
No, that's my problem. I can't.
Yeah, that's what I can't work out. Yeah.
So I would get the agenda on your computer if you have a desktop.
I haven't got a computer, Hugh.
You have no computer.
Yeah.
No.
Like shop
Actually,
I'd have to go run about 3 feet and keep looking at it and come back again.
Yeah. That's the problem.
Chairman, it does raise it.
Sorry, Leo.
Chairman, by your leave, it does raise an issue about about the councillors that don't have a video feed. They obviously won't be able to indicate that they wish to speak in the way other councillors can. So it'd just be worth being mindful of that, and perhaps just being mindful of it and offering them an opportunity to speak. I guess at the beginning of questions, just so that
if it's not pressing, if they need to jump in, if they can't use the chat function, then if the next person in the chat queue wouldn't mind giving way, then
I can't do that on the phone.
Yeah, just
to remind you, Chairman, the meeting has officially, or the time has now run over 1:30. Just to let you know.
We've got 15 online then. Shall we make a start? Everyone happy to get started? Okay, so obviously as we're public, I'll do it officially. So good afternoon, everyone, and welcome to the Health Overview Scrutiny panel. I'm Councillor Richard Tucker, the chair. Firstly, we need to run through a few procedural items before we go into the agenda formally. And basically a couple of paragraphs I'll need to read out for you is, this is the first of North Somerset Council's virtual scrutiny panel meetings being held under the virtual meeting regulations. We're using the Microsoft Teams software. The proceedings will have the same standing and validity as if they had taken place at a physical meeting at the town hall. We're streaming today's meeting. The YouTube link was published on the agenda. A recorded version will be available on the council website within 48 hours. And finally, please remember to mute your microphone when not speaking, as this will improve sound quality. And in terms of the order of play, speakers will be invited.
Okay, I'm in.
You're in, okay.
Okay. Speakers will be invited using a queue system within the chat function within Teams. And would all non-panel members please ensure both your audio and video feeds are turned off at all times unless you're invited to speak. So do we have any questions on that in terms of procedure and just the general running of the meeting, please? And obviously these are fairly newish times for all of us in terms of getting public meetings run this way. If we're all okay, then I'll move on to ask our officers to take a roll call of members. So I think that'll be you now, Leo. How do we want to do that? Alphabetical order of panel members.
Brent, are you ready to give the roll call?
I am indeed.
Okay.
Yeah. Can you hear me?
Yeah.
Not very well.
I'm sorry, I didn't hear that.
All right. I'll start from the top. Councillor Tucker.
Present.
Councillor Richardson.
Present.
Councillor Applen. You, Councillor Cherry. Thank you. Councillor Cole. Councillor Cole, I thought I saw you. I can see you. You're muted.
He's present.
Okay. Councillor Gregor. No.
Sorry, present.
Councillor Hampson.
Yes.
Thank you. Councillor Jacobs.
Yes, present. On phone.
Yes, thank you. Councillor James.
Present.
Thank you. Councillor Snaden. Councillor Solomon.
Present.
Thank you. Councillor Willis.
Here, sir.
And Georgie Biggs.
Present, thank you.
Thank you very much, everyone. That's the roll call done.
That's excellent. And now if we can go to the presenters, please, to ask them to introduce themselves. I think that's 4 or stroke 5. And should we go to the order in which they're down on the agenda, Leo? Is that probably the best way to do it? And invite Robert.
Yeah, sure.
Is Robert Woolley available, please? Is Robert Woolley there?
Good afternoon. Can you hear me?
Excellent,
Yeah.
Robert. Thank
Hello,
you very
Richard.
much.
I'm here.
Much appreciated. Thank you very much. Next, we have Colin Bradbury from CCG.
Yes. Good afternoon, Chair. Colin Bradbury here.
Excellent. Thank you very much, Colin. And Matt Lenny, Public Health, North Somerset.
Good afternoon, Chair. It's Matt here.
Excellent, Matt. Thank you. And I gather you had a guest from Public Health England with you as well, and we're probably going to bring him in under your slot.
Yep.
Would that be Damien Mellon? Would that be?
So it's Dominic Mellon, my colleague, Dominic Mellon.
Sorry,
So I'll let Dominic say hello.
Hi,
Dominic Mellon. I'm one of the lead consultants in health protection at Public Health England.
Very much appreciated, Dominic, and thank you for coming along today. And Gerald Hunt from North Somerset Adult Social Care.
Gerald is here. I did see him.
waved his hand, if that means anything.
He did wave his hand, yes.
He was
So
on the... Okay.
Yeah.
We can take that. That's okay then. Yeah, we can proceed then. Can we on to the agenda proper?
Yes.
That's
yes.
brilliant. Thank you very much, everybody. So obviously we'll go on to item 1 then, which is addresses from members of the public. I don't believe we have any, Leo. Is that right?
No, there are none notified, Chairman.
And item 2 then, apologies.
There were no apologies noted either. No apologies given, Chairman.
Thank you.
Leo, if I could just interject that Caroline Sherry gave her apologies to me. But,
thanks. We'll get that recorded then.
We'll note apologies. Yeah.
Lovely, thank you. Item 3 then, do we have declarations of pecuniary interest, please? Any to note?
Just noting my normal pecuniary interest that I receive funding. I'm a board member of Alliance Homes, who are a domiciliary care provider in the district.
Excellent, okay. You've got that accordingly, Leo, I take it. Lovely, thank you. Item 4 then would be the previous minutes. 2 parts. Firstly, the meeting of the 6th of February. Could I have a mover and a seconder on that, please? Or any questions if we have? I think you had something, Ruth, on. Was that on the 1st or the September one?
February.
It was this one. Would you like to come in on that one first before we...
Right, Councillor Ruth Jacobs, Colin Bradbury. On HEA 24, the last 2 lines of that is asking that you would check about GP surgery attendances, and if you look at it, and making appointments. I don't know whether anything was done about that, because I haven't heard anything, and it doesn't say anything anywhere else.
Apologies.
HEA 24.
HEA 24.
Yeah, 24, 6th of February, the last 2 lines.
HEA 24, 6th of February.
Yep.
Difficulties making appointments at St George's Surgery. He agreed to, yes. So I did raise that with the practice. I'm happy to follow that up if that is still an issue that needs to be addressed. Okay, I will follow that up. Thank you.
Right, would you let me know when you have? I'd be grateful.
I will. Yes, I will, Councillor.
Thank you very much.
Thank you for that, Ruth. Subject to that, then, could I have a mover and a seconder, please, that we sign those minutes off?
I'll second it if you like.
Sorry, Richard, I've got something to say about those minutes. Basically, it puts me down as present, and I was not there. I'd sent my apologies.
I do recall that, actually. We tried to move the meeting for you, didn't we? And it wasn't possible.
Yeah.
Okay, if we could just get that amended.
Yes.
Then, please. Thank you.
We will amend them as requested.
Okay, so I'll move that then. And did you say you were seconding then?
Ruth, yeah. Councillor Jacobs, I'll second it.
Okay. And in terms of voting then, Leo, unless we have anyone that says otherwise, we can assume that as taken.
Yes.
That's no objections. Then we'll move on to the second set of minutes for adopting, which was back on the 30th of September. If we can all remember back that far, it was mainly about Healthy Western. Happy to move that one, and if we have a seconder, please.
Richard.
Lovely, Vice Chairman. Thank you very much, or Ruth, that's lovely. If we can take that as okay, unless anyone wants to say otherwise or objects otherwise. Okay, we can take that as read. Then I move on to item 5. Matters referred by council, executive or other committees. I don't believe we have any, Leo, is that right?
There are none. No, there are none.
Right, so we can get on to the main body of the meeting then, basically. So that's effectively the main item 6, COVID-19, current health and social care position and the way forward. So obviously, just by way of introduction for this, we have huge pressures facing the health and social care sectors, or even even in normal circumstances. And under the current situation, and given the recent events at Western Hospital, giving wide concern within the community, it just underlines the importance of our role in scrutiny. And therefore, we've invited the Health Trust, together with the CCG, our own Director of Public Health, and the Adult Social Services team, to provide updates on the current COVID-19 situation and to begin the process of scrutinising the pathway to recovery. So on that note, then I'll certainly invite the Chief Executive of the University Hospitals Bristol and Western, Robert Woolley, to update us on the situation at Western General Hospital. And just before we start, Robert, would you prefer questions immediately after your presentation, or would you prefer to take them at the end after all the other presentations are finished? As a complete block, it's entirely up to you, obviously, as you came in after the agenda was published.
Well, I was going to say I'm in your hands, Chair. The committee might want to ask me questions straight away. I'm happy to stay as long as I can as well and be part of the panel, but I imagine there might be questions immediately.
In that case, if you're happy to take. Probably let you do the presentation first before we sort of butt in, because I know obviously that can slow things up. So we'll try and hold back with hospital-specific questions, and when you're finished, and we'll go from there. Okay, if you'd like to take it away, Robert, certainly.
Thank you, and I wasn't going to take a great deal of your time telling you where we currently are, but there are some key points to get across. And can I start by saying, Chair, that I absolutely recognise the width and depth of concern in the community about the situation at Western General, and the ongoing terrible toll that this awful pandemic is having right across the country, never mind locally, is the context for that concern. I do want to, through you, keep reassuring the families who've got loved ones currently in the hospital being cared for that we are still giving them the absolutely best care. The staff are working very, very hard to do that. So while we've closed, as we closed on the 25th of May, to new patients, including closing the A&E completely, nonetheless, we're continuing to care for patients inside the hospital and doing that to the very best of our ability. I'm hugely grateful to all of the partners in North Somerset and outside North Somerset in both health and care who've helped us ensure that there are alternative services available for Western residents. You know, we've got a clinical reception centre in place of A&E for any walk-in patients who still come, and the peer health practice and Sirona are helping to staff that after the Ambulance Trust set it up last week. We are transferring patients who need acute emergency care to other hospitals in the region, the BRI, Southmead Hospital, Musgrove Park as well. And I'm very grateful to those hospitals because there has been a flow of patients now who needs to be repatriated to Western as soon as we can. We've been retesting all the patients in the hospital. So we've done that a number of times now. And what we are seeing is that there's no evidence of in-hospital transmission taking place. And that gives us assurance that the steps we've taken to minimise the potential for cross-infection, to keep the inpatients safe, that those measures have worked. Of course, we continue to discharge patients when it's clinically appropriate to do so, but only when it's clinically appropriate to do so. And we're very careful about making sure that we're not putting known infection out into the community as we do that. I know that Matt and Dominic will talk to you about the work that Public Health England have been doing, and we've been working very closely with PHE to provide them with data about the staff in particular. So we tested all the staff last week. We're retesting the staff this week. I'm still waiting for the results this week, but we've done it twice precisely so we've got confidence in the findings that we get back. We've fed last week's information. We've got that. We've fed it through to PHE as well, and I'll leave our public health colleagues to talk about the findings that they've come up with. But it does appear now, as I understand it, that there isn't evidence of any significant transmission of COVID from the hospital into the community. And that, to me, is validation of the very prompt action we took last week to contain the infection spike in the hospital. And that is what's happened. So the staff testing from last week suggests that approximately 6% of all the staff we've tested are asymptomatic but have the infection. So that means they have the infection but they didn't know it, and no one around them would have known it because they're not showing any symptoms. That is a very significant finding. It's a finding that I think has significance not only for how we inside Western General ensure that we are managing staff appropriately and deploying staff appropriately in future. It's also of great significance for the BRI and all the hospitals in Bristol, but actually, as I was telling all the NHS chief executives in the Southwest this morning, it's of huge significance for the NHS as well. And so the importance of having repeat testing for staff to make sure that staff aren't in this position of unwittingly and potentially carrying the virus themselves from person to person. That's really important. All the staff who have tested positive last week are now self-isolating. They are not a risk to patients or to their colleagues. I still plan to reopen services as soon as possible. Now, the rate limiting step on that is making sure that we can do it when it is when we've got confidence it's entirely safe to do so. And the criteria that we have for that won't surprise you. It's that there shouldn't be any evidence of continuing or any onward transmission between patients inside the hospital, that the hospital should have been deep cleaned, and we've got a rota in place now for that deep cleaning to happen, that we know we've got enough staff to safely reopen services and that we can man those rotas for a period in advance to make sure that the services are sustainable, and that we can appropriately configure the physical estate, the wards and departments, so that we're really rigorous around social distancing, whether that's in outpatient areas or between beds in wards, and that we've got the right zoning so that staff, as far as possible, we're not putting staff at risk either of moving between areas that we know we have cohorted infectious patients and areas where we know patients are not COVID positive. So as it looks at the minute, subject to those conditions being met, we may be in a position to start reopening services next week. I still want to see the results from the staff testing this week and make sure that those conditions are met. We are likely, haven't fully decided this, but we're likely to reopen services in a phased way that helps our ability to ensure that we are safe in doing so. And we are looking at the prioritization with which we would reopen, and we'll be talking more openly about that next week when we've concluded that prioritization. But we do want to get A&E back open on the basis that it was open 10 days ago, and as well as making sure we've got the full range of services at Western General. Now, I know that the community wants to know why this has happened, and they want to know how quickly they're going to get services back. So I'm very anxious that I can explain when the services will be back. I'm just not in a position to do that today. And of course, we've got an incident investigation running that will take some time to complete, which is looking at all of the potential causes for the spike in COVID-19 infection that we've had in the hospital. But as we sit here today, no one, and I do mean no one, has got any evidence on which to say that one potential cause is more likely than any other potential cause. And I think all of us who are in this virtual meeting have a collective ambition to ensure that Western General, when it reopens, is as strong as it possibly can be, is as stable as it can be, that it is operating as we were talking about in September last year, as a thriving hospital at the heart of this community, that it is contributing to local employment in these terrible times as well, and that we are doing our best to keep the morale of staff up, and the staff are working. I cannot thank them enough for the efforts they've made and the resilience they've shown, despite the things they're reading in the media every day. And I think that plays as well across the public, in that we need to keep the confidence of the public in the hospital as well, so that when it does reopen, there isn't any hesitation about people wanting to access services, because we know already there's a national problem about people holding themselves back from the care they need because they're frightened of potential infection. So I'll stop there, Chair. I'm very happy to take comments that on anything I've raised, or indeed any other questions now.
Thank you very much for that, Robert. I'm sure. Sorry, Leo, you wanted to come in?
Oh, no, I was just going to give you the list of speakers, but sorry, I interrupted you, Chairman. Please do carry on.
Yeah, I'll just quickly sum up then, and much appreciated, Robert. In terms of one of those members of staff, actually, my cousin works there and was off with the virus after working in the coronavirus ward, which I gather is on the top floor. Just as a quick question, if I may get in first, please. Unfortunately, I can't access the chat function. And that is basically, what is the current capacity within the hospital in ICU? I don't know if you're able to answer that one now, or wait for some more questions and bundle them together.
No, that's fine. We've got 4 intensive care beds open. The intensive care teams in Western and Bristol are working phenomenally well together. I've been hugely pleased by how well that collaboration has worked. There are Bristol staff working in Western. There are rotations of Western staff back to Bristol as well. And we currently only have 1 COVID-infected patient in the Western intensive care unit.
Okay, thank you very much. And Leo, can you call the next person then, please? The next indicator.
The next speaker listed was Jeff Richardson, Councillor Richardson.
Carry on, Jeff, Vice Chairman.
I'll just unmute myself. Thank you very much for that, Robert. I realise you're obviously a very busy person, especially at the moment. I noted that you said that you're doing an instant investigation for the causes at the moment. If you don't know what the causes are, how can you be sure that you can reopen the hospital safely, because you don't know whether you're actually correcting the problems there were in the first place?
Well, that's I understand entirely the reasoning behind your question, Jeff. This is why we've set explicit criteria for reopening, and why we've done so much testing. We've tested all the inpatients 4 times now. We're about to complete the second full testing of staff, hospital staff. That gives us information we didn't have before about where the infection lies, where the liabilities may be, and of course we will want to make sure that the emerging findings from that investigation are playing through into our planning. But I'm quite clear that I don't want to wait 4 weeks or 6 weeks or even longer until I've got a report with a ribbon tied around it before I can open services. I've got the clinical leaders in the trust, including at Western, working with me to make sure that these safety criteria are met, and only when they're met will we reopen services. And of course we will review what we're doing in the light of the lessons from the investigation. Let me make clear, I've got no doubt there will be lessons for the hospital, there'll be lessons for the trust, there might be learning we want to take back to Bristol, and there may be lessons for the whole NHS, particularly about this issue of asymptomatic staff and how we manage that risk.
Well, I'll just ask a quick follow-up, Chair, please.
By all means, Jeff.
Is there a comprehensive, complete guide for hospitals for the processes and procedures they should be following under COVID? I'll tell you why I'm worried about this. I looked up online when I realised that this meeting was going to take place, and I found a complete guide for Australia. I found a complete guide from World Health Organization, which includes people arriving at the hospital for whatever reason, to the point that they leave the hospital and what procedures and practices should take place. I couldn't find anything for the UK at all. So I'm just wondering whether that document exists.
As I understand it, the NHS has been working to the pandemic flu incident plan, because of course this is an entirely novel virus. And indeed, inside UHBW, we've been using the WHO checklist, both the major incident checklist and the pandemic checklist. We've got our own trust-wide incident policies, and we're following our own internal outbreak plan at the minute. So while there isn't something that's got COVID-19 plan written on it, Jeff, there is best practice that the Trust and the whole of the NHS is following.
Okay, thank you.
Okay, who's next, Leo?
Chair, if you can put me on your list at some point, please.
Councillor
Willis, if you can put me on the list at some point, please.
And also Councillor Jacobs.
Okay. Who was next on the list then, Leo, and see if they're happy to give way?
The next on the list was Hugh James, Councillor James.
Are you okay for Ros to come in?
Does one want to come? Yeah, one can come.
And then perhaps if you come in, and then we'll bring in Ruth, and then we'll go back to the list. Does that make fair sense? If I could call in Ros next, then, if you're happy, Hugh. Thank you.
Thank you, everybody. Very difficult on the phone. Afternoon, Robert. It's Councillor Ros Willis. I've got just two questions there. So you've sort of part answered my question. First one was cross-working staff with other trusts and it within care homes with Western Hospital. You've part answered that staff are rotating from the 2 areas, but is that still continuing, the fact that we have this situation at Western? And also care homes. I know some staff work in care homes as well as the trust. So if you could answer that first for me, please.
Right, sorry, just getting myself off mute. We have taken strict action to ensure that staff who have been going to agencies so they can work in other settings, including care homes, Ros, are no longer able to do so. They have to work in one institution and no other. And we've made that very clear with the agencies as well. I can't say that it wasn't happening, but as soon as we realised the risk involved, we've taken action to stop it. And then in terms of staff working between designated infectious areas inside the hospital and non-infectious areas, we of course, we have to use the staff according to their skills in the best possible way, and it would be ideal if I could duplicate everybody and only have some who are working in the infectious areas and some who are only working in non-infectious areas, but the staff numbers simply don't allow that. In every case, staff have the personal protective equipment that is recommended by Public Health England to us. There has been no shortage of PPE in the hospital, and in every case, staff are trained to use it and trained to keep themselves and patients safe. And that really is no different to any other hospital.
That's lovely. Thank you for that. So my second small one is staff in uniform. We know that there's been numerous conversations in the past through the panel throughout all the years that I've been with the panel about uniforms being worn now, from the hospital going home, etc. Whereas before there were lockers and you used to leave your uniforms at work and come home in your own clothes. Is that now stopped? Are staff having to take their uniforms home to wash, or what is the situation, please?
I wish I could guarantee that there weren't examples of staff wearing uniforms outside the hospital. It's entirely against policy, and we send frequent reminders to staff not to do it. And of course, staff who at the minute who are particularly working in COVID designated areas are wearing scrubs, and those scrubs are routinely washed. They're all taken off before anyone leaves the site and so on. So I'm sorry that's a bit of a mixed answer. I can't give you a guarantee about it, Ros, but the discipline, particularly around scrubs that have been worn in infected areas, I'm sure that discipline is intact.
Yeah, thank you. I understand about the scrub bit. It's just that I know we've had a problem in the past with it, and I think still is. So perhaps that's something that could be looked at again when we're out of this war, and that we are able to, as you say, learn lessons from things, and maybe we can go back to that area of staff not wearing uniforms to and from work. I think that might help a lot of people to understand. A lot of my residents have said, well, I suppose it's happened because what it's like with the public. So thank you for that. Thank you, Chairman.
Thank you, Ros. Is it Hugh next, and then Ruth? Then we're back to the queue.
Thank you very much. And firstly, I'd like to thank obviously all the NHS staff who are working around the clock at the moment. It must be very high work levels. You mentioned the media and communication is sort of a thing that you bared in mind, and that media representation could reduce confidence in staff. So a union representative, Joanna Kay, said that the staff members felt left in the dark from the trust and managers. There was obviously the whistleblower, so a whistleblower felt the need to communicate to the press because I assume communications with managers and the trust just wasn't strong enough. I went to a training weekend by PricewaterhouseCoopers on crisis management last weekend, which was really useful. They said that open and honest communication was definitely the key for acting during a crisis. Western General seems to have acted a bit more like Fortress Europe. So what communications plan do you have for contingents? What communications plans do you have in your contingency plan for major outbreaks? And when did you know about the outbreak? And when did you notify the wider system, including Public Health England? Thank you. I don't know if that's too big a question, but maybe that's...
No, I'm happy to respond on all of that, Hugh. I reject the suggestion that we behaved like a fortress. The values of the leadership inside the trust, and particularly the commitment to support staff and to communicate very openly to staff, is precisely what has underpinned Bristol getting 2 outstanding ratings in a row from the Care Quality Commission. I've got absolutely no doubt of that. It's slightly bemusing to me that some of the statements made publicly by union representatives overlook the fact that there's even union representatives in the communications group who are spreading the daily messages we put out to staff onto staff Facebook pages and other groups. So what I would say is that the decision was taken very fast, and it was taken over a bank holiday weekend. And that gave us an enormous problem in trying to communicate with staff on that bank holiday Monday when we chose to close to new patients. And of course, staff were missed, and of course, staff were upset and wondered what had happened, and I can't blame them at all. We knew there was an issue certainly in the week before. We had a plan going into that bank holiday weekend to manage the situation. We were in full communication with NHS England, NHS Improvement, Public Health England, the Clinical Commissioning Group, all through the weekend, and we had a clinically led set of discussions going on about the timing of any further action in addition to the action we'd taken as a trust in the week before. And that led to a decision which was a decision agreed right up and down the NHS from top to bottom very late on the Sunday night. So from that moment, I and everyone in the trust and in the hospital was scrambling. We were scrambling to deliver on the crisis communications plan that we've got. We were scrambling to tell staff, and I'm sorry, we did put the staff before the media. But despite the accusations of not communicating, we put out 2 proactive public statements on the Monday, on the Tuesday. We did 2 rounds of media interviews in the same week. I'll be talking to the media again today. We've got other statements going out. So I think if there is, I accept that the appetite to understand what's happened and what is happening is insatiable, and I can't be communicating enough. But of course, we are doing our best, is what I'd say.
That's really assuring. Thank you for that, and thank you for appearing in front of us today. Just for a specific thing that was in the whistleblowing to do with BAME staff members, Black and minority ethnic staff members. Obviously, it's being discussed in Parliament at the moment. I imagine it's very much part of the inquiry, the investigation report that you're doing. Can you confirm to us, though, just how many of the staff members working in the coronavirus ward were Black and minority ethnic, and were there assurances made once it became clear that these staff members were disproportionately likely to catch COVID and die? And obviously the disparities report's only just gone out 2 days ago, but there was knowledge that this community were disproportionately affected, despite the fact usually they're disproportionately not affected by more, they're disproportionately less likely to be affected by mortality. Was there guidance from NHS England, NHS, and was this followed? And, what do you think of the quite serious allegations that you discriminate, that the trust in management discriminated particularly against BAME staff members who were locum or cleaners in putting them on the front line of coronavirus?
It's a horrible allegation, it really is. No one inside the trust has raised any concern, either formally or anonymously, and we have been making clear to staff all along that there are multiple routes for raising concerns. That's concerns on any issue, and not just the risk that's being run by our Black, Asian and minority ethnic colleagues. I don't have numbers, Hugh, for how many BAME staff have been working on COVID wards. I can look into that, but what I will say is that the majority of the medical staff, the senior medical staff at Western General, are from a BAME background, and we've known that all along. Those consultants, when I talk to them, when members of my senior leadership team talk to them, do not raise issues of discrimination. They tell me they feel supported. Right across the trust, we have been making it entirely understood that there should be individual discussions going on with managers, and we have a risk assessment tool, which again, we followed the NHS guidance around this, but actually we've tailored our own risk assessment tool now with the input from senior BAME medical staff, and we've launched that this week inside the trust. So anybody who feels that the trust isn't doing enough hasn't been coming to me or to management about that, and we have got the tools in place, and more importantly, we've got the messages in place about the responsibilities that senior staff have towards vulnerable staff, especially BAME staff.
That's really good to hear, and I'm sure that those staff members will come forward. And just finally, if it's all right, Chair.
Go on then, you 3 for 1.
You say that unfortunately we're not able to recognise the points of failure yet, and there's an instance investigation coming. Obviously, I thought it was 40% of staff members, but you say 50% of staff members that have been tested positive?
No, absolutely not. No. No, the 40% figure was something given to the media and taken totally out of context. So that was 40% of very high-risk staff, and only a sample of high-risk staff. We've now tested all the staff, and a little over 6.0 staff are infected.
Brilliant. It's good to know that it's not such a high figure, because that is very alarming.
Yes, indeed.
The question was, would you be willing to come back to this after all the firefighting and heat, this HOS panel, after all the firefighting and heat has gone, for an inquiry day, just to look back when we're not in the middle of the crisis? Because there's lots of questions to ask, and we can only really focus on the ones that we think are really essential.
I'd be delighted to.
Thank you very much.
Appreciate that. Thank you, Hugh. And we've got Ruth Jacobs next. No
Hello,
trouble.
Robert. Thank you very much for your report, Councillor Ruth Jacobs. Well, my query was to do with communication, I have to say. But how can I say, problem is that I'm getting a lot of people saying to me, residents, saying to me, is there anything else anybody can tell us about what's going on? Now, are we going to give out another press release in the near future? And if so, what would it contain? And if not, why not?
Sorry, I pressed the wrong button. Yes, we're going to put out a statement today, but it describes work in progress, Ruth. It describes the fact that we want to test all the staff again and that has built in another week's delay. But that means that when those results come back, we'll have very high confidence about the number of infected staff and high confidence about our ability to staff the hospital safely as we restart services, which I would dearly like to start doing next week.
Yes, I understand that. It's just that people are saying we don't know the true story, do we? They're saying to me, I'm not saying that to you. And what I feel is that communication is vital. Absolutely vital, and I think we could do a bit better. I'm not saying you personally or even the hospital, and thank everybody on all our behalves for what they do. But the public pick up things, as you quite rightly say, from the media, which are out of context, and they don't know how can I say, to take in what actually is happening. And that's, I think, important.
I couldn't agree more, Ruth. You know, my commitment is that we will be as proactive and as open and honest as we possibly can be with the public. No doubt. So if there's any lack of communication, it's only because we're just so damn busy trying to manage the situation.
Okay, I understand that. Thank you very much.
Thank you.
Ruth. We'll go back to Leo with the list now in terms of the chat queue. And who's the next indicator, Leo?
The next person indicating is Councillor Mike Solomon.
Would you like to come in, Mike?
Thanks very much. Good afternoon, Robert. Couple of questions for you. One is, I understand from reliable sources that it can take up to 6 or 7 days now for swab tests to get back. Why is it taking so long? The second question I have is, are you going to put any extra resources in place for the planned reopening to help the staff, and how do you foresee you know, the additional help they may need with the reopening going forward?
Thank you, Mike. The question on swab testing and testing results, others in the virtual room may be better placed to answer than me. What I can say is that we've put a testing hub on the Western site, so we're able to turn the results round quickly. Of course, it isn't as simple as just turning them round. We then have to get the results back, and we have to communicate with each individual member of staff. So we very rapidly realised last week that we needed to put more resources into that in order to make sure that the information is flowing as quickly as possible. And Western, unfortunately, it's one of the commitments I made prior to the merger, was that we'd put the Bristol computer system into Western. We haven't been able to do that yet, so I'm afraid we're working with quite an old and slightly clunky computer system and a lot of manual data, and that's awkward. But we are making progress on moving to one computer system across the sites. In terms of extra resources, yes, I've told my team that we need to do whatever it takes to make sure the hospital can reopen safely and is fully supported to do so. And I think one of the areas, again, not trying to prejudge the results of the investigation, but I want to be sure that when decisions are being made about where a patient coming through A&E or what have you, where a patient should be placed inside the hospital, because segregation is so important to keeping the potential for cross-infection down, those decisions are supported at a senior level clinically, and they're not left to someone who is having to take a responsibility in the middle of the night, perhaps, that you know, they could do with professional advice on. So that's one particular area, and there will be others, particularly around staffing, around ancillary support as well.
Thanks for your answer, Robert.
Thank you.
Thank you. And just on testing, I heard on the news today that there were a lot of tests that have to be redone because they were sent to America, and they came back wrongly. I don't know if you picked that one up at all, or presumably hopefully that doesn't apply to us in Western and North Somerset. But if you
again, I don't know, and again, others might be able to comment. But no, that's not affecting our immediate staff testing regime in Western.
That's reassuring. Thank you, Robert. Who's next on the list then, Leo? Thank you, Mike.
The next speaker is Georgie Big.
Georgie, can you hear?
Thank you very much.
Come on in.
Thank you very much, Chairman. And thank you, Robert, for coming this afternoon to update us and be so open about the information. Just wanted to clarify something that has been discussed already, and that was that initial press information about the percentage of staff that were infected. And that did cause a lot of confusion, of course, and also, I suppose, a lot of extra concern, because it sort of led people to believe that was a lot higher than actually you were trying to illustrate. Being that it was a portion of the staff, and you have since been doing much more intensive testing, you've mentioned that staff are moving between the hospitals in terms of resourcing. Are you able to say in total how many staff have tested positive over that period of time? Actual numbers as opposed to percentages.
What I can say is that 80 staff are now self-isolating or shielding at home. Whether that is the exact correlation with the numbers coming back positive out of last week, I just need to be cautious about, because I don't have that information in front of me. But that's what I do know, that we're looking at 80 staff who are self-isolating. I say at home, they could be self-isolating in the appropriate place.
And that is over what period of time? From over the last 2 weeks, or?
Well, no, of course, the number is a point in time.
Yeah,
number.
exactly.
So that's the number today, and we know that the national advice is to self-isolate for 7 days once you've been tested positive. So of course that the number over the last 2 weeks or more will be higher.
Okay, and is that something that you could let us have in the future, that figure?
Yes, I will do so. I will get the noting that the number will change on a daily basis, and I'll need to establish exactly how frequently I can get that number, because it depends on the frequency with which we do the staff testing going forward. This has been a very exceptional exercise, and we are one of only a few hospitals in the country, I believe, to have tested all staff at this point, and we've done it precisely as part of our response to this problem. But I'm happy to look at how we can keep tabs on that and keep you informed of that figure as well.
Thank you. I think it's helpful, I think, to inform the bigger picture then, and the relationship between, and I'm assuming that number relates to the whole, the staff for the whole of the trust as opposed to just Western.
Yes.
Yeah. Okay.
No, I'm sorry. That's what. No, I beg your pardon. That's Western. We haven't tested everyone in Bristol.
Right. So the 80 is the current staff self-isolating for Western.
It is.
Yeah. Thank you. Thank you very much.
Thank you, Georgie. And I understand, Robert, that we've got 1,700 at Western. Is that right? And 6% of the 1,700 is where we're at. Does that sound right to you?
That's right.
Thank you.
Thank
Next in the, thank you, Georgie.
Thank you.
Next in the queue, Leo, please.
Is Councillor Havison, Councillor Karen Havison.
Come in, Karen.
You've already, thank you for doing this. It must be a bit of an ordeal. You've already partly answered my question. Has this implications for the whole of the NHS? Because how typical is the Western situation in other hospitals? If we cannot test all staff in all hospitals, how likely is it that this is under the surface, hidden in other trusts and other hospitals?
Well, I think this is precisely why we are ramping up testing and why the testing for staff is such a priority. And of course, Public Health England, and again, PHE colleagues in the meeting can talk more about the test and trace programme that's been introduced and has been prioritised for introduction at Western as well as elsewhere in the country. So I think there is at least a theoretical risk, Karen, but it is a recognised risk. And of course, the excuse me, the measures that we take in the NHS to prevent infection, including maintaining excellent hand hygiene, following the best infection prevention and control best practice, making sure that distancing is happening even between hospital staff, and making sure that increasingly we do test, and that appropriate protective equipment is available, staff are properly trained to use it and know when it needs to be used. All of those things are things that every hospital in the NHS is already doing in order to keep the risk of this sort of infection spike down. Does that answer the question?
I think you're on mute there, Karen. Is that okay? If that's okay, we'll move on then, Leo, shall we? Next.
Okay. Next person requesting to speak is Councillor Mike Bell.
Come on in, Mike, Executive Member.
Hi everyone, and thank you, and afternoon, Robert. Really helpful as ever overview of the situation. I just wanted to sort of query three things really. The first is that the principal question that I think a lot of people will be asking is, how did it happen and how did we get to this place? And I think that's already been addressed in the sense that clearly there will be a point in the future when we can take the time required to really drill into the detail and understand that. But I think we should note that the right things have been done since the outbreak became apparent, and I really do applaud the work of the Hospital Trust team and all the staff there for doing the right things as quickly as they possibly can.
Thank you.
That said, I think the communications point, and it's come through in some of the questions this afternoon, it is a key one, because whilst I recognise that everything was moving at a very fast pace, and in a context where everything was moving at a fast pace, because the reality is that we've all been in this world where there's been an element of, dare I say, making it up as we go along in terms of what's happening, what the guidance was, what the rules were, what the right reactions were, what the available of equipment and testing and so on was. So I totally recognise the pressures, but I do think one of the key problems in terms of the communications was that early on in the first couple of days, the Trust wasn't putting across a lot of detail in terms of the numbers and the facts of the situation, and was trying to reassure people that this was normal and under control, but actually wasn't underpinning that with detail or with a public face to account for that. And of course, that gap in communications was filled by speculation and in some cases leaks or disclosures from staff who had obviously been given slightly different information to that which was communicated publicly. And I think that is a real key learning point, that even if the answer is that you don't know, I think the sooner that people can get out there and front it up and be transparent about what they know and what they don't know, including the facts, the better it is. It's not helpful to go into the detail of all of the public communications, but I think if you were to honestly evaluate what you did over those first couple of days, I think you would recognise that probably it could have been done differently and more effectively. In terms of where we are now, what can you tell us about the contact tracing for staff and family members and anyone else that those that have tested positive have has been undertaken? Because I think that's obviously a key issue. All of this happened just as the national tracing system was kicking off, so we were absolutely guinea pigs in that sense. But can you just give us some assurances about what's happened in terms of contact tracing of the positive tests within the hospital setting?
Thanks, Mike. In response to the comms point, I'm happy to reflect on how things could have been done differently in the first couple of days. As I alluded to you in our communications in those days, this wasn't entirely within the gift of the hospital trust. So while I take the criticism on behalf of the trust, I think there's learning perhaps that needs to go more widely. The phrase you use about guinea pigs, I think, is quite accurate. I think Western has been a guinea pig on all sorts of dimensions of what is being described as outbreak management, right up and down the NHS and more widely. And that in itself plays into some of the dimension around communications as well. And of course, let's not be naive. There were political interests playing in how some of that media was running out. The contact tracing, I need to ask Matt and Dominic to fill you in on, because of course the track and trace operation is actually put together by Public Health England, and the way the operation works, the numbers contacted, and indeed the results, the data coming back, is for them to manage. We are collaborating very closely in terms of Western General, but the policy itself is not really for me to comment on.
Okay, Mike.
So yeah, that's fine, and maybe we can come to the contact tracing as part of the later discussion with Matt and Dominic.
That's fine, thank you. Who's next, Leo?
There is another request from Councillor Havison, but I'm wondering whether that was actually picked up in her previous question.
Chairman, may I just have a quick one? It's Ros.
How many more have we got on the list, Leo?
I've just had another request from Councillor Richardson to speak, but the only one outstanding was before that was Councillor Havison, but I believe she may have picked up the issue she intended raising in her previous question. So I would think the last one is yeah. So we just had a request. Was it from Councillor
Willis?
We had one of our telephone requests from Councillor Willis.
Okay, so no one hasn't spoken.
And Councillor Richardson.
That's fine. Shall we pick up Ros next then, is it?
Thank you, Chairman. Thank you, Robert. I just wanted to come in and say, Robert, obviously I'm such a fan of Western Hospital. My husband calls it Wonderful Western. I love my Western Hospital, as I love all my other trusts, but Western is a very special place. And, we've worked so hard to keep it and where we are. What can we do to help? What can we do? What can I do? I'm at home shielding with a husband who's a cancer patient, so I can't physically be out there. but what can we do to help? I know I tried originally to help deliver PPE with Colin Bradbury and Julia Ross, etc., and we got that sorted out with NS North Somerset Council in the end. But is there anything we can do now to help? What can we do?
Thank you for offering, Ros, and for your support of the hospital. And actually, it may just sound a bit sort of bland of me, but actually, I think the issue is in the arena of support. I think it is about helping the trust and the hospital articulate just how much work is going on to put this right and to restore services as quickly as possible. And while I can't give you a kind of day-by-day plan or a deadline for when services will be back up and running, I can say very honestly that I'm determined we get them up and running as quickly as possible, and I'm very hopeful that we might be able to announce something next week about that. So my commitment is to keep you and your colleagues fully informed as to what's happening, and hopefully between us we can fill the communications gap that was left out of last week, Ros.
Okay, thank you. What I'll try and do is put out to some of my residents groups some little bits and pieces to try and reassure them of what the conversation we've had today, and then that'll spread it around maybe, and if others, we can do the same. I know some Twitter, some don't. I don't do any of that, but I do have a couple of residents groups I can put it to, so we'll go that way to try and get it out there. Okay, thank you again, Robert. Thank you.
Thank you, Ros. Leo, we had Karen and Jeff as the remaining two, is that right?
Yes. That's correct. I do, as I said, Councillor Havison just mentioned that she had dealt with the issue that she had dealt with she has dealt with her issues. The only outstanding question now is from Councillor Richardson.
Vice Chairman, come on in, Jeff.
Hi, thank you very much, and thanks again, Robert. Just one last thing. While I was looking around in preparation for this meeting, I came across a report that came from St Augustine's Durban Hospital in South Africa, which had a similar outbreak to the one you're enjoying at the moment. And their conclusion was that the main transmission route was through multi-use equipment like stethoscopes. So I'm just wondering if you could reassure us what procedures are in place to make sure that that kind of equipment, which is transported, if you like, by hand from one place to another, is being disinfected, and what procedures there are to make sure that's happening.
Yes, thank you, and it's a very good point, Jeff, that the procedures absolutely are in place that set the expectations for the disinfection of equipment that's being used or moved multiple times. The extent to which we are able to monitor compliance is itself constrained by the nature of the coronavirus and the need to try and minimise the, if you like, the number of auditors that are going on to wards and clinical areas in order to check things like hand hygiene and equipment disinfection and so on. So this, I know, will exactly be one of the things that is looked at in the investigation to determine whether it's been a factor. And I shouldn't speculate. I think we may find there are multiple factors in play, and I will need to make sure that every single one of them is addressed going forward.
Okay, thank you very much.
We're complete with the list of questions to Robert now, are we, Leo?
Yes, we are. That's right, Chairman.
Thank you very much, Robert. We really appreciate you coming along today. We know it wasn't as part of the initial agenda that was published a week ago. Obviously difficult times for all concerned. Thank you very much for taking the questions and answering honestly. You're welcome to stay on for the rest of the meeting if you want to hear the presentations of other NHS and council colleagues, and maybe answer as a panel after that. It's entirely up to you, or if you've had enough today, I can fully understand too. So the choice is yours, really.
Thank you, Chair. I'm pleased to have come. Thank you for the opportunity. If it's all right, I will leave you now because I've got meetings, other meetings, and hoping to talk proactively to the media this afternoon as well. But I'm grateful for your attention this afternoon.
Thank you very much.
Good luck, Robert.
Thank you
very much, Robert.
Thank you very much.
Much appreciated. And you're welcome to come along as a follow-up at any time, and I'm sure we can arrange informal briefings and meetings, particularly during this time. We can set up something virtually, and fingers crossed as we move forward. Thank you very much, Robert. Appreciated. So we just move on with the rest of the agenda now then, Leo. So
yes,
as remaining under item 6, the next speaker we have is Colin Bradbury, Area Director of the CCG.
Thank you very much, Chair. Good afternoon, everyone, and thanks for the opportunity to present today. So I was asked to give a general update around the current situation, as has already been noted upon a number of times. We are in an unprecedented period within not only the NHS's history, but you know, across the board and society. So I have a presentation that I am happy to share on the screen, just to take colleagues through. You will have had this in your packs, but I'll take you through page by page if that's okay. Can I do a quick technical check that people can see my screen?
Coming up fine here.
Excellent, thank you.
Yeah.
Okay, so
sorry, can I just ask, is that what we have on the iPad, Colin?
That's correct, Ros. Yes, that's
the
thank
you. Nothing
the briefing.
Different, right?
Nothing
Okay.
different, no.
No, thank you.
So I'll go ahead to the. I'll just say before I start, actually, that people have had the pack in advance, so I'll take it as read. I'll just go through, if not least for the interest of time, the highlights, if I may, and very happy to take questions either at the end or as part of the panel later together. So moving on to slide 2, just to say that this is done within the context of the Healthier Together partnership, what's called generically across the country the Sustainability and Transformation Partnership. And I think I must say that the work we've done to build partnership working across the system in Bristol, North Somerset and South Gloucestershire has paid huge dividends during this pandemic crisis. And I think I shudder to think where we may be if we were where we were maybe only a handful of years ago in relation to organisations ploughing a much more individual furrow. There is obviously more to do, and ironically, this crisis has actually, I think, accelerated and improved partnership working and communication, which I think is, if nothing else, a benefit from this terrible situation we find ourselves in. Moving on to slide 3, for those on the phone, you can see the summary there. As we know, historically so far, the rates of infection in the southwest and therefore locally have been lower than the nationwide average. That is no cause for complacency, but it's something that I think we need to be aware of in the context, and I'm sure Matt and Dominic could speak more about that later on if required. This is an ever-changing and very dynamic and fluid situation, of course, and so it's something that we're wrestling with as we try to plan for the reinstatement or the ramping back up of more business as usual services such as elective care, while continuing to be able to mount a safe and effective response to the COVID challenges. Moving on to slide 3, this is a slide about Western General Hospital. Given we've just had Robert's presentation, very little to add other than to say, if you'll allow me, that the CCG are confident that the Trust's whistleblowing policy, or the freedom to speak up policy as it's called, is very strong. And I know that Robert and his team are personally committed to this wholeheartedly. And so, again, that's not to be complacent when we take any sort of, concerns raised by any member of staff or the public extremely seriously, but just to say that we are assured within the CCG that there is a good process to allow people to raise concerns in a safe and appropriate way. And I hope that anyone with those concerns working in the hospital or any part of the healthcare system would be able to do that. I think the other thing just to say on this slide is to give a vote of thanks, add my voice to those who have already acknowledged the dedication and hard work of Robert's staff, but not only UHBW, the whole system is supporting the situation in Western General Hospital. We've already heard that the GP Peer Health Partnership and Serona and the ambulance service are giving direct support, but also, of course, surrounding hospitals are taking patients from Western that would otherwise have been admitted through the Western site, which is causing additional pressures on the system at the moment. So it's something that the whole system is responding to, and obviously making every effort to support the return to the position we had prior to the temporary closure to new patients. Moving on to slide 5, I think the only thing I'd say there is that, as Robert has already said, from the NHS side, Gerald, I'm sure, will talk about the care side where appropriate, but the PPE situation within the local system has been at times difficult, but there's not been a case where we've run out of any PPE. There have been some occasions, as there have across the country, where there's needed to be mutual aid in the sense of one hospital is running low on one supply, may borrow some temporarily from another hospital until national supply lines are able to replenish their stocks. But there's at no point has the appropriate PPE, as far as I'm aware, been not available for NHS staff within Bristol, North Somerset or South Gloucestershire since this pandemic started. I think the other thing to say, and it's the final bullet point there, is that PPE is a key consideration in relation to returning to more business as usual services. We will have a big backlog, of course, of elective care, of planned operations, and that's a concern. But also as well, there are issues around productivity, if I can put it like that, because the protocols for safe donning and doffing of PPE add a great deal of time. So if you're running a theatre list where you would previously been able to do 4 operations, the amount of time that needs for the additional PPE to be taken on and taken off again, if you see what I mean, will affect that productivity and therefore affect the number of slots you can offer for any given care pathway. Moving on to care providers, I plan to say very little about this as Gerald is on the call and is presenting later, other than to say we're extremely committed to working hand in glove with care providers and the local authority as the Commissioner of Care to ensure that there is a good link between NHS services and care provider services. Moving on to slide 7. I put this slide in as an example of, again, where we may be able to accrue benefit from the lessons and the experience of the COVID pandemic, in the sense that, for example, in primary care, it has accelerated some of the transformational change pieces that we were looking to do anyway. So you can see there that there's been a big increase in the number of online and remote consultations happening through primary care, and a very big jump in the number of prescriptions that are issued electronically for pharmacy pickup. And those are the sort of things that, in relation to day-to-day workload, make primary care much more efficient. And I think that some of the experiences born out of necessity for primary care have helped some of the primary care providers see what the real potential is for digital transformation, and we still have only, I think, scratched the surface, and there's quite an exciting future in relation to that. Of course, wherever necessary, there will still be the facility to lay hands on a patient, if I can put it like that, where there is a direct need for examination, but there are a lot of services that can be provided remotely, which is more convenient for the patient and also makes for more efficient primary care delivery. Moving on to slide 8. This is a changing picture. This slide deck was put together about a week ago, and there have been changes within the level of demand in the system as a whole. I'll just move on to slide 9, which sort of illustrates this graphically. You can see that when the coronavirus hit and then subsequent to lockdown, there was a very significant drop off of demand. You'll see here this graph is minors and majors, so essentially that is put very crudely the way that an A&E department would be split, with, as the name suggests, minor illness and injury, the walk-ins and the conditions that can be dealt with and turned around and discharged immediately, as opposed to the majors, which would be the more serious attendances, some of which will require hospital admission. You can see that there's a pronounced drop in both of those attendances across the system, although they have started to recover in terms of those numbers. Now, this is, as I think Robert alluded to, a concern that and this is by no means unique or different in this part of the world compared to the rest of the country, but we are concerned to make sure that the people who need emergency care feel able to access it, and there's been communications to try and ensure that people understand that the NHS is open for business. By the same token, it is the case, we know that around 30% on average of people attending A&E could be dealt with elsewhere in the system through either minor injuries units or primary care services, leaving the emergency departments free to concentrate on the more major issues. So again, the question that the whole of the NHS is wrestling is, how can we bank some of the changes that are positive and are going in the right direction, whilst at the same time ensuring that people that do need emergency care feel able and willing to access it. As you can see, the numbers starting to rise again is in some ways reassuring, but there's still a lot of work to do to understand that and properly unpick those patterns. And I would say if we had a graph for primary care presentations, there would be a similar precipitative drop in demand, which is now starting to rise again. So it's not just that A&Es were less prevailed upon during the height of this crisis, but also across the board in terms of NHS services. And that was really the presentation and update for you. Happy to, as I say, take any immediate questions now or wait until we've had the other presentations, and then if there's anything on the panel I can help with, very pleased to do so.
Thank you very much for that, Colin. That's a very good overview. Much appreciated. Can you hear me okay? Excellent. Thank you.
Yes, I can.
Lovely. Yeah, obviously, as I'm not able to get onto the chat queue, I wonder if I could dive in with the first question then, please. It is interesting that you mentioned obviously about the partnership working, which is pretty crucial during the current time. And I suppose, what would you say that the pandemic has told you about the nature of these partnerships locally, and how could you change them for the better in the future going forward? It's I don't know obviously there are a lot of issues that you would look at within that, but just overall.
Yeah. Thank you. Well, I certainly don't think that the partnership working was poor by any stretch of the imagination to start with. I think, as I say, we had a strong basis to work from. I think one of the things it's done is it's accelerated our mutual understanding of people's priorities and the pressures that they face. So we have daily calls, or sometimes, it feels like hourly calls across the system, and people like Matt and Gerald, I'm sure, will recognise this, where it gives you a much clearer understanding of the various pressures and priorities across the system, as I say. So I think what it's done is it's forged a greater mutual understanding, and it's also required us to think more laterally about how we can ensure that services are better configured to meet the patient's needs. And also, as I said in my presentation earlier, it's maybe for for anyone who's been less embracing of change, the necessity is the mother of invention. So I think, although it's only one example, the digital transformation in primary care is a really good example of where we've been able to demonstrate what is possible and what is safe and reasonable to do through digital means, which may have taken far longer if we were doing it under our normal pace, as it were.
Thank you. Got a list of speakers on the chat, Leo?
Yep. Yes, we have councillors Hugh James and Jeff Richardson lined up to speak.
Okay, it's Hugh first.
You might want to also check with councillors Willis and Jacobs.
Yep. I'll ask this afterwards once everyone's spoken, because I think it's something that applies to Public Health England too.
And we could possibly take some emailed questions after, as we discussed in the preamble to the meeting. Obviously, there'll be a lot of follow-ups. So it was Jeff next, then, was it?
Yes, it was. Yes.
Okay, over to you, Jeff.
Okay, thanks, Chair. Thanks, Colin. I've got sort of 2.5 questions for you, if that's okay.
Sounds like we haven't got a long queue, so that sounds all right, Jeff.
Okay. The first one was about the backlogs for non-COVID conditions, obviously, that we're building up at the moment. I know you said there obviously is an issue with that. Can you give us some idea of what the size of that issue is? The second one was, can you confirm that the Clevedon Hospital hasn't been used for COVID cases, please? And the third one really is, can you give us some indication of what COVID has done to community health and mental health services? Thanks very much.
Thank you. That sounds like 3 rather than 2.5.
It grew as I was asking. Sorry.
That's fine. As I've come to accept, very cogent and clear questions. Thank you. So in terms of the backlog, I'm afraid I wouldn't be able to give you an overall number. It will depend on specialty by specialty, because of course there will be some areas of care that already had, for various reasons, more of a capacity challenge than others. So I can, if you'll allow me, I'll take that question away and see how I can give you a more sort of sensible answer on that, other than to say that, of course, inevitably, and again, there is no reason to think this is any different here than it is in any other part of the country. There is an inevitable backlog of elective care that's building up, but I'll get the appropriate numbers for the system. In terms of the Clevedon Hospital, I presume you're talking about the inpatient unit. So it's certainly not been the case, as far as I'm aware, that the community hospital beds have been ring-fenced for COVID-only patients. There will have been the appropriate infection control measures taken for all bedded care within the NHS, as per the guidance, and the appropriate use of PPE. And of course, in the minor injuries unit, we will have also the possibility of people who are COVID positive presenting either with related or unrelated ailments. So I think the important thing is that there is the appropriate, we can give you assurance that the appropriate PPE and infection control measures are being taken by Serona to counter that. The third one on the community impact and mental health, well, as I mentioned briefly in my presentation, there has been a concomitant drop-off of demand in the community and primary care services, in the same way as the emergency department hospital care that I showed a graph for. mental health is one that we're absolutely focused on at the moment, because there is, again, across the country, a concern that there will be a level of pent-up demand, and also, given the stresses and strains that many people have experienced during lockdown, not least for some in relation to things like housing and employment, there is likely to be an additional demand. We have set up additional capacity in terms of helplines. We've converted the Safe Haven unit in North Somerset to a phone line service, and that's up and running and has been for a few weeks now. And also AWP, the mental health statutory provider, have also provided more helpline capacity. We're working with our mental health provider colleagues to plan for additional capacity to be able to meet extra demand, and we're monitoring the situation closely. At the moment, we haven't seen, as far as I'm aware, the last time I saw data for this, we haven't seen a spike in demand yet, but I'm sure that is in the offing.
Thank you, Colin. Just to be sure then about the Cleveland Hospital, there weren't any COVID patients taken into the inpatient area on purpose. It was just if they happen to be there. Is that the case? Not that I'm aware of, but I will check. I will double check that with Sirona. It's certainly not the case that they were it was in any way ring fenced as a COVID only facility. Okay, thank you.
Thank you, Jeff. Thank you, Colin. Next, Leo.
There are no more. Councillor James will take his question later.
Okay, thank you.
Oh, unless you want to check with councillors.
Ruth and Ros?
No, I haven't got anything, thank you. No, I'm just trying to juggle holding a phone, a pen, a piece of paper, and get my iPad back on.
Yeah,
so.
I'm making sure I've got my ducks in a row.
And someone was knocking on the door as well. Yeah.
You're doing
Thank
well.
you. No, I'm okay. I just gathered where we are. I was on the public health bit, so sorry. We're fine, Colin, on where we got to. Thank you.
No, that's great.
Thank you.
Thank you very much for that, Colin. Very much appreciated. Obviously, you're hopefully staying on to take questions further on with the rest of the panel.
Happy to. Yeah.
Yeah, that's brilliant. Thank you. So obviously we go on to part 2 of item 6 then. North Somerset Council Director of Public Health, Matt Lenny, and we've got Dominic Mellon from Public Health England alongside him. Welcome to you as well, Dominic. Thank you very much. Over to you, Matt.
Thank you, Chair, and good afternoon, everyone. I'm just trying to see if I can share the presentation with you, but while I do that, because I've lost my share function, so I'm going to see if this works.
Hold our breath.
Yeah. The theory is good. The practice is sometimes less skilled, especially in my hands. But
I know what you mean.
so I'll keep trying with that. But just to also pick up on the start of the discussion this afternoon. So obviously Robert was very kind to join us and to talk through the situation at the hospital. Just wanted to draw members' attention to an email that will have come through to you since the meeting started from Joe Walker, the Chief Exec, just giving an update on the broader situation. So just briefly to reflect on that, that's a piece of analysis where we've been given good support from our colleagues in Public Health England. That's been taking some of the data out of the Hospital Trust and looking at that alongside the other information that we have about rates of infection and cases of infection across the wider community. And just to say that that piece of work has now just been completed, and so I want to draw your attention to it. And I suppose the overall message from that is that we're pleased to say that when you take into account the specific number of cases that are related to the hospital, both in terms of patients and staff that are North Somerset residents, that we're not seeing a bigger issue in the wider community in terms of the numbers of cases. So when you take those cases out, the background level of cases in North Somerset is more or less typical to what we'd be seeing in neighbouring authorities, because we have seen a rise in cases in recent weeks, but that can be attributed to the additional issues in and around the hospital at the moment. We've also seen an increase in the number of testing opportunities in North Somerset, partly because we have the regional testing centre close by at Bristol Airport, and partly because we've got the mobile testing unit, which is situated at Locking Road car park in Weston-super-Mare as well. And in any outbreak, what you would normally do is go through a process of understanding there was a rise in cases, and then you go and find more cases because you're testing more people. And we're seeing that at the moment. But actually testing and finding more cases is helpful for the overall management of COVID-19 as a pandemic, because the more people you test, the more now, given the new test and trace system, the more that we can then follow up on those identified cases, contact trace the people that they may have been in close contact with, and then offer appropriate advice around self-isolation and further testing as needed. But I just wanted to start off before I launch into the bit about outbreak control plans to draw your attention to that information. And if you were happy to look at that while I try and run through the presentation, then happy to pick up questions as we go along.
That would be ideal. Thank you very much for that.
Through you, Chair.
Sorry, Leo, carry on.
Through you, Chairman. Matt, if you'd like me to run the presentation my end, happy to do so.
If you could, Leo, it's just not loading up for me at the moment, so that would be great. I can see it on the screen, so at least I can give you a nudge if that's okay.
Okay.
So what I'm just going to run through at the moment is a request that's come to us from Department of Health and Social Care, and this is coming to all local authority areas. And in recognition of the challenge of the pandemic, we're all being asked to develop local outbreak control plans. So this is recognising that the pattern of infection will be varied and not equally distributed across the country. And at any one point, one local area can be subject to a greater number of infections and may require additional actions to try and mitigate those additional risks. So at the moment, I suppose we talked about that already today. We've had a particular situation at the hospital. The hospital has gripped that and dealt with that in a number of ways around testing, but also around infection prevention control approaches. So it's taking that principle and applying it and having a systematic way of dealing with any additional pressures from outbreaks associated with particular facilities or a bigger rise in cases in the wider community that might need additional action. So the first slide there is saying, and this was shared before the launch of the test and trace service last Thursday, so some of this looks a little bit out of date, but it's essentially recognising that you want to get into this good cycle of testing, tracing, containing the spread of the virus, and then enabling further action to do more testing as you need to try and bring any spread of the virus under control. What this is as well, and it talks about it at the bottom of the slide there, it's also about engaging the public very effectively. So in the information I've just referred to in terms of saying how we think there isn't a bigger community issue in relation to the hospital outbreak based on the analysis we've been able to do, it's also about us being very proactive, talking to our public about this is the time when we really need to be very alert. We need to think about this virus circulating in our community because it's not always easy to recognise the symptoms in everybody who might be a case. So it's so important that you continue to practice the good standards around social distancing, around hygiene, around isolating if you're not feeling well, requesting a test, and the other ongoing work around infection prevention control in particular settings through things like personal protective equipment. But to keep talking to the public and keep reminding them as the guidance changes, this is what you need to do to stay as safe as possible. So maybe if we can move to the next slide. So this is now referring to the fact that by having an outbreak control plan, you can try and improve the speed of response. So you've got a clear set of steps and procedures that you might use locally to try and take a localized approach and use all of the resources and the skills and the abilities in your area. Build on the local knowledge as well. So recognizing that it's different in each local authority area or each place. And you want to be able to think about the needs and the circumstances of your local population. So North Somerset, with a large population in Weston-super-Mare, smaller towns, and then a more rural area is going to look very different to a London borough. So we need to be able to plan for what works for our population and how we can use our links with key stakeholders, whether they be schools, whether they be community groups, or whether it's colleagues in primary care, whatever it might be. We want to make sure that we are working together to respond appropriately. The plans also give us the opportunity to think about what expertise we can bring in. So, for example, the strong support we've had from Public Health England, how we can work with the wider civil society through local resilience forums and any other forums that may give us more impact in the actions than we might want to take. And some of that is also about coordination. So it's about being clear what we can do locally, what support we can get regionally or nationally, and as we move further down in dealing with the pandemic, there may be more resources that come to us, particularly from national government. So it makes reference, for example, to the Joint Biosecurity Centre there, which is meant to be like an intelligence hub that can give you more live information about what's going on in your community and are there particular issues that you might want to address. We need to see more about how that's going to work, but at least it feels like there are more tools available to us to think about what a local response should be. And the bottom part of that slide talks about additional money being provided to local authorities to support this work. We're not entirely clear yet how that's going to flow, but in the plans we can start to try and make some assumptions about if we had some additional resource, how could we use that most effectively? And I would suggest some of that will be very much within North Somerset as a place, but some of it might be collaborating with our neighbouring authorities and with partners across, for example, the STP footprint, so Bristol, North Somerset and South Gloucestershire. Some might be working across the local resilience forum, which is Avon and Somerset, and some might be at regional level as well, because it'll all depend on where we can get the best value out of the resources and the most effective response. Okay, maybe move on to the next slide. So in terms of thinking about an outbreak control plan, we've been 7 themes have been identified nationally for us to think about in the process of developing one. So the first one probably will be very much at the heart of local government. So our key settings of care homes and schools. We've already done a lot of work with care homes and worked up some really good partnerships with our community provider, Serona, great leadership from our colleagues in adult social care, public health support in there. So that's an area that's been pretty well developed and lots of attention on this over the last while. And we've also been liaising with our colleagues in schools to make sure that they feel confident using the national guidance and the support structures around them in terms of risk assessments and all of the controls that they'd want to have in place as well. Second category is about high risk places, locations and communities. So that's about doing some assessment of, are there other places within our local authority footprint that we might be particularly concerned about how patterns of infection might grow quickly. So, for example, you might look at large employers and what the working practices are in employers, and we're already giving good support through our regulatory services team to help businesses as they come back online to make sure they're following the right procedures to minimise risk and to follow the national guidance. The third point there is about local testing capacity. So that's about, as I've already said, we've got quite good access actually in North Somerset already, being close to the regional testing centre. We've got the mobile testing unit in Weston for the foreseeable future, but that may change over time depending on where the patterns of need are. And also we have other options around providing specific tests to locations if that's appropriate, so doing larger scale testing if that's required, and home testing options as well if that's more appropriate. So it's about being flexible and working out where we should target our resources most effectively. The fourth point is about contact tracing in complex settings. So the contact tracing service is now up and running, and we've seen that in action live in North Somerset at the front end of the learning curve in using that to support the response for the outbreak at the hospital. And I'll maybe let Dominic say something about that in a little while. I'll run through the presentation. We could come back to that. But that's very welcome as a means of being able to respond and follow the lines out from a particular number of cases, follow them through to other individuals who may be at increased risk, and trying to stop the transmission. Point number 5 is data. So that's all about trying to combine our data sets. And we've been having conversations with colleagues in the CCG and across broader sort of settings in terms of national government as well, about how can we get the best possible oversight of what's going on in our community, the best kind of early alert systems to where problems may be developing, and then be able to respond as quickly as we can. 6 categories: vulnerable people, so recognising that we have a number of people in our community, and particularly for North Somerset, we're having a much higher percentage of older population, as well as people with long-term conditions in certain concentrations. We would want to make sure that we are providing the best possible support for those people, and we've seen already in North Somerset some great responses around the North Somerset Together initiative and other community-led support for vulnerable people. And then finally moving on to local boards, so that's having governance around how do we keep an eye on this plan, how do we make sure it's doing the right things, and then make sure that people feel well engaged and well supported to be able to take the right actions. So that's quickly running through that slide. And then finally just seeing that a local plan sits within a regional or national context. So we'll have our governance arrangements locally. We do have a health protection assurance group, which has been in place for some time. That's a structure that we can use to get the professionals together. And if we had a bigger outbreak issue, we'd be able to bring that grouping together to look at what are the responses that we need to do. And that would be a group that I would chair. We have sort of strategic coordinating group approaches. So certainly within the local authority, that sits within the corporate leadership team, led by the chief executive. But we can also look to our collaboration with our colleagues in the wider health and care community system. And then, as it says at regional level, the local resilience forum, using the strategic coordinating group there to bring all the partners together as needed. And then the development of a local outbreak engagement board. So we're developing at the moment, just to give you some timescale, these plans are due to be developed during the month of June. So we're starting to bring together some ideas about how we could develop an engagement board that provides that local leadership. At regional level, we'll work within our different forums that we have, and at national level we'll use all of the resources that are available to us, like the Test and Trace programme, like the Joint Biosecurity Centre, and any other resources that we think will be helpful to us in responding to any local issues. And then the final slide on number 5 is just recognising the fact that the approach that's being developed nationally is that there'll be some pilot areas, of which there are 11 in the country, and the one for us in the southwest is being led by Devon, with Cornwall as an additional area of focus. And just to give some assurance that, so for example, I'm liaising closely with my counterpart, the Director of Public Health in Devon, who is providing some insight to us as a group across the southwest. And I know chief executive to chief executive as well. In the local authorities, there's conversations happening there as well. So we'll take all of the learning we can out of the early adopters and then factor that into our plan. Plus we have the live experience of dealing with some of the issues we have been dealing with over the last couple of weeks, which will also help to inform our plan. So we'll try and bank that early learning as quickly as possible and put it into the outbreak control plan, and make sure that we engage on the draft and then use that to manage any situations as we move forward. And I think that's probably I'll probably stop there, Chair, if that's okay, and then happy to take questions.
That's excellent, Matt. Thank you very much. Much appreciated. That's a very good summary. It'll be interesting to see how that 300 million gets allocated and split, I think, going forward. I wonder if I could just dive in first with a question. There was something in the national press that said that we're one of the 18 councils whose COVID rate is still rising. And someone's written to me and said, shouldn't we therefore be implementing a local lockdown around the beach and the seafront? This is something that quite a few people have said to me, so I didn't know what your view might be on that. Maybe it's something we've still got kind of up our sleeve if needs be, but or are we kind of at that stage where we really need to be thinking about that?
So I think in response to that, the analysis that we've just had the support from Public Health England to do is really helpful to us, because that's looked at the actual cases within North Somerset. So we know that we've had an increase in cases, but because we've been able to identify that that's been driven by the hospital outbreak, the background level, if you like, is more in tune with what we were seeing across the southwest region. So I think this is always about a moment in time. You see what you can see at that moment, and you try and make an assessment on that. And at the moment, it's not suggesting that there are additional actions that we need to take. But we will always stay vigilant, and we'll keep watching the data. And if there are other patterns that come out, and if there are effective controls that are available to us, then we would look to see what we could do in that space. But I guess it's back to my point that the most effective control that we have is in the practice that we operate as individuals and try and encourage others to do. So if we maintain social distance, if we follow the good hygiene, and if we stay alert to symptoms of COVID and report those quickly, we'll all be helping to manage the spread of infection. So it is about that constant dialogue with the public and encouraging our communities to constantly think in that way. And if we get that bit right, that will really help us alongside the test and tracing of active cases to try and keep it in check as much as we can.
Thank you for that, Matt. Obviously, a lot of people have been commenting about the influx of tourists since the whole of England was opened up again, and obviously that's kind of been on the news quite a bit with in recent couple of weeks. So obviously that's something is an ongoing situation, as you say. Any more lined up in the chat room for questions, Leo?
One for me when you have, please.
We do. We have.
Yeah.
We in addition to Councillor Willis, we have Councillor Havison, Councillor Richardson, and Councillor James in that order.
Okay, we'll go to you first then, Ros, and obviously continue with the list.
Okay, thank you very much. So on the test and traced, it's that issue didn't answer for the time coming back from the test being done and coming back in that we were talking about with Robert, and also the test and trace, how it is working for us in Western. As already said, we are the test and trace centre, guinea pig, or whatever it is we're being called. So I'm wondering what update Matt or Dominic can give us on that.
Okay, if it's okay, I might let Dominic say a little bit about how the test and trace system has been connected in and how it's been supporting us in the Western outbreak, if that's okay.
Thank you.
Thanks, Matt. Thanks, councillors. So with regards to the issue around testing, first of all, and delays between getting tests and getting results through, that's not an issue that I've been made aware was a specific problem now. So I'll go away and discuss with our public health laboratory whether or not there is any good evidence that's available around any potential delays, and I'm more than happy to present that back to Matt and to the panel. In terms of how test and trace is working within North Somerset, and particularly as part of the outbreak investigation, you'll be aware that test and trace wasn't active at the start of our outbreak investigation on the 23rd, but was introduced nationally on the 28th. In the meantime, we've been able to use the capacity within Public Health England, within our health protection team, and some additional capacity from what we're calling the tier 1 of test and trace, so that's the most acute end, to follow up the cases, particularly within the staff who've been tested positive within the hospital as part of the outbreak, and to ask them to identify people that they've been in contact with whilst they may have been infectious, and then contact those individual contacts to give them appropriate advice and support. So after the 23rd, we had a number of contacts that were processed through our team, and then from the 28th onwards, in fact, actually from the day before, when the national test and trace came online, all of those positive cases were automatically referred into that national service and have been followed up. So they've either been invited to complete online questionnaires to be able to get information about their movements and about the contacts that they potentially may have come into contact with, and also to get those details so that they could then be followed up in turn. And so in total, we've had 90 cases that were identified who required follow-up through test and trace in total since the beginning of the outbreak, and have been referred through. And from those 90 cases, we've been able to identify a total of 166 contacts who would then need to be followed up and given advice.
Is that, can I just say, is that the Weston-super-Mare area or North Somerset? Is that from the hospital?
That's right. That's specifically with regards to the cases identified from the hospital.
That's lovely. Thank you. Thank you.
Thank you very much for that, Dominic. Good information. Thank you. And who was the next one then, Leo?
It was Councillor Havison.
Hello, Karen.
Okay, thank you. I've got two questions. One very general, which is probably a little bit above all our heads, but I would really appreciate your input, and one much more specific. And my really general point is that as this is a global pandemic, we should not just learn lessons from local UK areas, but worldwide, and especially with comparable countries. Now, for obvious reasons, we are all painfully aware that the UK is one of the worst performing countries in Europe as far as controlling this outbreak is. And one of the best ones, which I've got a personal interest in as well, is Germany. So I've made some very close comparisons. And I know that the health system in Germany is much more devolved, which I feel very strongly has helped a fast and efficient response right at the beginning, because they have managed to involve, they could react locally because the spread across Germany is quite lopsided as well. It's much worse in southern Germany compared to northern Germany. So the individual parts of Germany could react at their own pace. And the other thing is that testing facilities are much more devolved. All the university labs were involved, all the hospitals have got labs, whereas the system with Public Health England is very centralised and very unwieldy. And I just feel that in an outbreak like this, it simply cannot respond fast enough. So I just really would like to start a debate about what we need to learn from this to allow us to be more flexible in our response, because we have been very slow and we've been very sluggish, and it has cost an awful lot of lives, and I'm very, very sad about that. Now that was my first point. The second point is much more specific. I have become aware that some local authorities in Wales, for example, Ceredigion Council, have started their own tracing system in early May. Was there anything that would have prevented us doing something similar, or would that have not been tolerated by Public Health England? Because I feel if you can respond much more locally, again, talking with my previous point, it would have been much less unwieldy and much faster.
Thank you very much for that, Karen. You think you've underlined what an overly centralised country we are, really. But over to you, Matt and Dominic.
Okay, so I could pick up the answer to that. So I think your point about learning from other systems is a good one. There's lots of different understandings from people applying different approaches. I mean, some of this is hard to absorb in the speed of the response, but I would completely agree with you that a reflective piece of learning, and as much as we can learn off good approaches from elsewhere, we should try and incorporate that into our response as we go along. In terms of the structure of the healthcare system, I suppose it's hard for me to comment on. That's something that we have to work with. And I think back to the points that Colin was making earlier, what we have tried to do is work as effectively in a partnership way as possible in the circumstances that we're in, and we'll continue to do that. In terms of the doing our own tracing system, our own contact tracing system, well, there are the system in Wales is very different as well in terms of how public health works, so that may offer some more flexibilities, but we have some real practical barriers in that the system that is used to monitor all infectious diseases is very much held within a national database at Public Health England, so your ability to identify and follow through and maintain records for people in a tracing system is very hard to do without being part of that system. Otherwise, we potentially have risk of starting something that we couldn't complete effectively. And what we did know is that the work was being done to develop the national system. So in terms of resources as well, that's another issue, is what resources local authorities have to be able to set this up. And in reality, the level of resource within individual public health teams is relatively low. So working within a national system and continuing to get good support from our colleagues at public health at a regional level is our most effective way of putting that into our overall toolbox for how we can try and manage the pandemic and respond most appropriately, I think.
Can I comment as well?
Please do, Dom.
Yeah, so I think I would just also comment that obviously the health protection team within Public Health England sits at the Southwest regional level. I'd like to emphasise how strong the relationships are between our health protection team and each of the local government public health teams across the Southwest. Contact tracing and outbreak management is not a new issue. It's something that we've been doing for a very long time. Of course, we've got to make that work within the context of the COVID pandemic. But we have and continue to work very closely with the local authority leads through, for example, environmental health teams, where we've been engaging in other outbreaks. And so we'll take a lot of that learning and a lot of that underlying relationships into our next stage of local outbreak planning. So I'd just like to comment on that, please, because I think it is highly relevant. And with regards to whether or not we would have been able to mobilise any quicker, I would just comment again that although the national system came on board on the 28th, our regional team were able to support the local response by undertaking contact tracing before the national system had been launched in this case. Thank you.
Very interesting watching that dispatches programme on Channel 4 last night as well, in terms of the history and the reactions. Is there anything else you wanted to come back on that, Karen? She's muted. It should be okay. We'll move on, shall we, Leo?
Next one, Chairman. Yes, next speaker is Councillor Richardson.
Hello. I had a couple of observations, I guess, and then a question. So first observation is that the timetable that you described there, Matt, seems to be at odds with the timetable for lifting restrictions. The second one is that in terms of high-risk places, I hope we're taking into account the lake in Clevedon, because as much as we wish that people will observe the social distancing, it's very clear that actually at the lake they don't. And my question really is, what's happened to the phone-based test and tracking system, which seems to have disappeared, and how does that link in with what we're talking about here?
So I presume by the phone base you mean the phone app system?
Yes, I do.
Yeah, okay, that's fine. I just wanted to double check. So that's a system that still may come online. We don't have details of how and when that might happen yet, but that's still an ambition to provide that as an additional support to the traditional human-based system of track and trace, which is in place now. So we'll watch with interest to see how that might develop in time. And just to pick up your point about high risk places, and talking particularly about the Marine Lake in Clevedon, which I see most days when I'm out walking. It is a challenge, and I suppose it is a challenge as well about looking at within the framework that we work within about what control measures you can put in place in certain public places. So local authority enforcement tends to focus more around businesses and the immediate confines of a business rather than large gatherings of people in public spaces, particularly public spaces that can be accessed from a number of points rather than a single gate or entrance point. So there are challenges within there for us as a local area in terms of the ways in which we can try and manage a situation. But that's something that I think we'll continue to debate as we develop our outbreak control plans, and we'll continue to take guidance from nationally in terms of whether there will be any changes in legislation or expectations of local authorities in the way they should act. And I think that, we'll just have to see how that develops over time. But I understand your concern, and I suppose it is going back again and again to our public and to adults and the parents of children, particularly sort of teenage children, to try and reinforce the importance of them taking responsibility of ensuring that people are protecting themselves and protecting others.
Thanks, Matt.
Could I add to Matt's comments?
Certainly, Dominic.
Just with regards then to high-risk settings and where test and trace fits into this, there's an important part of the test and trace process, which is that as we contact cases to find out more about the people they may have been in contact with, we're able to effectively build up a picture of where we may get coincident cases and contacts. And so it's through that process that we're able to contribute additional intelligence to local teams to help us to signpost where transmission may be going on within the community and potentially take more targeted, responsive action where that's felt to be appropriate. Thank you.
Thank you. Is that okay, Jeff?
Yeah, that's fine. Thank you very much.
Thank you very much, Dominic. Leo?
Yeah, the next speaker is Councillor James, followed by Councillor Bell, Councillor Mike Bell.
Okay, over to you, Hugh.
Thank you very much, Chair. And thank you, Matt and Dominic. Given the announcement during this meeting on the community spread of coronavirus, in both your professional opinions, can we now generally reassure parents, schools and teachers that it's safe to reopen schools after June 8th?
So yeah, happy to pick that one up. So communication is going out to schools. I was on a Teams call with head teachers of schools yesterday where we were talking, I was giving them an update and saying that we were hopeful that we might be able to communicate with them today. So what we have been able to confirm is that, there's no evidence of that wider community spread. So therefore, the advice that was given last week, in the absence of specific evidence about whether that was the case or not, now we've moved beyond that and we've got some evidence that actually there isn't the spread, then we would, so it is for each school to make their own decision making as part of their discussion with their governing body, but we don't see any reason why they can't move to that if they feel comfortable in making that decision. And we would support them in their individual decision making. We know that they've been using very effectively the guidance from Public Health England, the different risk assessment tools, and all of the practical measures that have been put in place in schools over the last while. And remembering that a lot of schools have stayed open as well, because they've been providing really important support for key workers and for more vulnerable children. So it's a case of saying that there's no evidence to suggest that they can't now start to extend the number of children that can come into a school, given what we found out over the last few days in terms of the investigation. So,
brilliant, thank you so much. It's really good. Oh, sorry, Dominic.
I was just going to add that our priority really from the outset of the investigation was to be able to analyse the data we were getting from the hospital to be able to inform Matt and the council more widely about the relationship between the hospital outbreak and the wider community. And whilst it's taken some time to get us to that position, I'm very pleased that we've been able to contribute to that and support the council in its approach with the schools.
Thank you so much. I hope it will be much easier for governors and for leaders to make decisions now they've got that clear data. It was a huge transformation from last week, so thank you.
Thank you very much. Thank you, Dom. And you're next, Mike.
Yeah, thanks, Richard. I just wanted to make one comment and then one question for Matt. Just just listening to the discussion, I think the important point in terms of where we are with the current cases is just to emphasise what they've said around the outbreak clearly being linked to the hospital. So if we take that out of our statistics, then Western and North Somerset is much more in line with the overall regional position, and I think that's a really important point of reassurance for local people. And what that obviously then also means is that there's no evidence that the increased numbers of visitors that we've had, particularly in Western but across North Somerset, have actually led to an increased number of cases in the community. In fact, we know from the evidence that the work that Dominic and PHE have done is that the community case levels in Western are actually similar to those in Nailsea or Yatton or other areas. So we don't see evidence of that disproportionate impact. Having said that, I think it's important that everyone should expect case numbers to continue to rise in the coming days and weeks. And we will see newspaper headlines that say that for those two key reasons. The first is Matt's point about more testing inevitably meaning that there will be more positive cases. But secondly, I think it's also really important for everyone to remember that we are not out of the woods as a community or as a country. The virus hasn't gone away. So we're obviously still going to see new cases being identified, but hopefully what we can be reassured through this process is that the rate is beginning to decline in line with what we're seeing in other areas. So I think it's really important for members to bear that in mind. The one question I've got for Matt around the local outbreak control plans is just that point about elected member oversight and what opportunities there will be for a local member-led board to help monitor outbreak control plans, and particularly the communication with the public. And given what we've heard earlier in the discussion with Robert Woolley about the challenges around communication, I just wonder what thoughts Matt has got around what that will look like, and also whether there'll be an opportunity for the HOSP panel to be formally represented on that oversight board. I mean, obviously we sort of hope that we never need to use it and deploy it, but I think it's worth bearing that in mind and thinking about it now.
Yes, thank you, Mike. I think that's a very good point. So we're looking at different models of what's happened in some of the pilot areas and how they've set that up and what might be effective. But I'd agree with your point. It would be very useful to have overview and scrutiny involvement in the development of that panel, so that we've got a clear sense of what we think good looks like, and then we can monitor how effectively we've performed against what good should be if we have to use it in practice. On the communications level, yes, I think there is a really good leadership role, and I think that's one where elected members play a particularly important part about being those representatives in the community, where through you we can provide information and support which will keep local residents well informed and to try and prompt them towards the things that we might ask them to do to help us try and deal with the pandemic as effectively as possible. So at the moment, we're pulling together some of the examples from elsewhere, and hopefully from about the middle or end of next week, we'll be able to start circulating around a draft of that for comment, get some engagement on that, and then over the next sort of 2-3 weeks, we'll be able to knock that into shape and come up with something that is based on a good range of perspectives about how we can work really effectively with our community to try and protect their health as effectively as we can. So I'd welcome a lot of conversation about that.
Thanks very much for that, Matt. Thanks for that answer. Is that all okay? Do you want any supplementary at all on that, Mike? Or
no, that's absolutely super. Thanks.
Excellent, thank you. And next on the list, Leo?
There are no more speakers listed to speak.
That's fine. Thank you very much. Much appreciated to you both there, Matt and Dominic. That was a good overview. Thanks for all the questions that you've answered there.
Thank you. Thank you, Chair. You're very welcome.
Thank you. So that takes us on to the third part of item 6 then, the final presentation, which is People and Communities Head of Commissioning, Gerald Hunt. If you'd like to come on in, Gerald.
Okay, Leo, are you not going to put up the other slides rather than that slide?
Oh, you want the other slides?
Yes,
Fine.
please.
1 second.
So thank you for the opportunity to update on the commissioning aspects of COVID. Obviously, our care providers have equally been through some pretty challenging recent events. So as you will have received from the slides this morning, which updated the bullet points of structure for this presentation, the first area obviously is ensuring that with the national planning for demand for the COVID impacts applied locally, worked through with Sirona as in terms of the community response, and for social care in terms of the hands-off from Sirona. You'll see that we procured or commissioned some substantial additional capacity in the care sector. The modelling for that demand for social care has changed dramatically. We anticipated in the early national modelling 80% increase in an 80% more activity than what we are actually experiencing now in terms of the modelling. So in actual fact, what we've been doing is reducing some of those beds. But clearly the impact of access to PPE, the impact of the incidences at the hospital, and the likelihood of the providers taking discharges has constantly meant that we've had to review and look at those capacity plans. It probably is interesting just to describe, that there are 3 areas. So P1 is the Sirona offer in support at home. P2 is Sirona's offer of support following hospital discharge in a care home setting or in Clevedon Hospital, and P3 is a care home setting funded through North Somerset Council. Albeit there are different arrangements in terms of the COVID period. And clearly what we've had to do is plan for the handoff from Sirona. And in addition to that, there clearly has been the offer from the community support sectors. So moving on to the next slide. So given time and presentation fatigue, I'm sure I do want to just flag that the wellness service is in operation. That is supporting well over 100 service users. And if you move to the next slide, and that is dealing in 2 pathways. The first one is, in a sense, is from North Somerset Together, where it is identified that via the community hub and via voluntary sector groups that actually individuals do need more support. So there's an opportunity to escalate into the wellness service, but equally in terms of hospital avoidance and work via the ICC, there is also an opportunity to de-escalate packages of care to the wellness service. So it has been seen as a key area in terms of linking pathways together in terms of the support that we offer. Move on. Another plug around technology. We've through winter funding and subsequently extended through the COVID NHS funding. There are a range of technology options that we've been looking at in terms of supporting people in periods of self-isolation in the community, and those are opportunities that we will seek to take further as we come into the recovery stage. Carry on. So the ICC, the Integrated Control Cell, everything's a cell, I'm afraid, that just recognises how, in terms of hospital discharge, both operational services and our commissioners work closely with Sirona and indeed the North Somerset Wellbeing Collective in terms of making arrangements for discharge and how patients and service users move between those pathways. Carry on. We should recognise that during this crisis that we have moved towards a 7-day service, so extensive brokerage and social work support is provided at weekends and bank holidays to support hospital discharge and the wider response that we're making. So clearly there has been an awful lot of partnership working, as Colin indicated. A theme of this is just how closely we've been working together and become more aware of each other's priorities. Finally, in terms of the slides, there have been, in terms of domiciliary care is different to the care home sector in a sense that what we've actually experienced is an increase in workforce in domiciliary care during this period, and a reduction in unmet need and backlogs for domiciliary care. But we have put a number of initiatives in there to support that, which I think will have a longer term future. Clearly, when it comes to the future of social care, we can anticipate that there will be changes in terms of what services demands will be. Currently, there is obviously a reluctance in terms of care home settings and a preference for workforce for domiciliary care, community-based services. So in terms of the analysis, I know members have asked for more details around statistics, particularly with regards to care homes. And you can see plotted there how Bristol, North Somerset and South Gloucestershire have experienced deaths in care homes. There is specific COVID related data, but it is quite unreliable over the period of time. And what is better to look at is the total number of deaths and what are the excess deaths. And as you can see, there has been clearly an increase in the period, particularly in April, and North Somerset's figures have slightly taken a different line to the other two. And you have seen an increase in recent weeks, although a very sharp drop back in the last week's return. So in total, 369 deaths in care home settings. But that has been pretty much throughout the year the same as usual, apart from in April, where it did appear to roughly double. Non-elective admissions for care homes. This is all data from the capacity tracker, which I'll talk about in a minute. Here you can see obviously a very sharp drop right across the board as the crisis happened. I think what's interesting here is that there have, that Western and Wirral is one of the highest areas for care home admissions, which clearly is a subject that we need to work on jointly to try and improve. And in terms of the impact on the care home sector, this has come from the capacity tracker, which is a requirement that all care homes now do. Some members will be aware that the capacity tracker looked at vacancies in care homes. That was something that we hadn't promoted the capacity tracker till it's been repurposed for COVID data, and we have in the last 3 weeks supported its development, and I'm pleased to say that North Somerset now has the highest usage from our care home sector in terms of the responses required by government last week for the free areas. As you can see, we've got around 84% capacity, which is certainly not a commercially viable position to be in for a very long time at the moment, albeit there are a relatively small number of services that are in a critical level of occupancy at the moment, with certainly nearly half above the 90% position, which would be a reasonably satisfactory position. But clearly this is the capacity tracker will give us the opportunity to really focus on those services that might be in need of financial support in the context of where outbreaks have led to significant occupancy problems. Interestingly, the outbreaks in care homes follows a similar pattern in terms of sort of like spiking in April and again in the last couple of weeks. What you've also received today is details with regards to the care home support plan that is a requirement that we've submitted last week. And within that, care homes were asked to respond to a series of questions. These are generally around infection control measures, which we've been developing in partnership with CCG and Sirona. The one that perhaps is most pleasing to report on is that 94% of the care homes, or 93% of the care homes, felt that they had sufficient PPE during this period, by far the highest of the three authorities. PPE has been a challenge with changes in guidance, some limited supply at times, but we have provided an emergency supply to all of our care providers throughout the period. As I referenced earlier, what we will need to do is consider how customer practice will change in terms of community set services, the use of technology, and what will happen to the care home sector in terms of capacity and future demand. We're committed to refreshing our market position statement in the next 2 or 3 months to reflect how those changes will influence future demand for social care. Any questions?
Thank you very much for that, Gerald. Particular relevance, of course, for Weston and Clevedon, given our the number of care homes and our demographic age profile. One somebody asked me to raise was, what do you think the main lessons learned if you had to prepare for secondary rise in cases? You kind of touched upon it during the presentation, but kind of in a nutshell, would you say?
Well, I suppose the benefit we have is that, as I said, with the 80% reduction in the expected activity, in many ways we were prepared for something a lot worse. So the second surge, which might be worse, we would obviously hope that we've got sufficient capacity in place. Clearly, that would be where our challenge was, as everywhere, was PPE supply. One would hope that PPE supply by any second surge will be more robust, which would give us the opportunity to, certainly from a social care perspective, manage those demands.
Like someone told me who worked or knew the outlet place for the PPE, that there was a bit of a over dependence on a single supplier, and when they did a stock take there, it was nothing like what was supposed to be. So whether they hadn't kept on top of the stocks, I don't know. But whether you've got any information on that, obviously lots of hearsay flies around, haven't there?
Are you talking nationally or locally now?
Locally, Western.
No, certainly we've acquired PPE from a variety of sources. Some of it directly purchased by ourselves, exported from China, also from the LRF deliveries, and also from mutual aid with the CCG, etc., and other partners. So it is not down to one supplier. I think it's in terms of just the sheer global demand for the same equipment.
Thank you, Leo. Do we have lists on the chat questions?
We have Councillor James and Councillor Solomon in that order. And Councillor Gibbons.
Okay, Hugh, Mike and Catherine. Okay, Hugh.
Thank you very much, and thank you, Gerald. You and your team have been really responsive via email. It's been really helpful. I think it's really good to see that no care provider has run out. It's worrying that that's something we need to worry about, but it's brilliant that the local authority have supported RAD-rated areas like that. The one worry, which I've communicated to you, is the huge increase of PPE supplies, how that's going to damage the long-term operating model of all of our social care providers. Have conversations been had, especially considering the NHS are represented here? Have the NHS offered to underwrite costs for social care providers to make sure they can viably operate in the future? Because this could be lasting until February. It could be lasting a very long time under very, very difficult operating costs. PPE.
Yeah, so the funding of PPE is a very complex issue. Clearly, it is a shared responsibility across a number of stakeholders. The local authority has had two generic pots of money, the 3.6 billion that you'll be familiar with, of which some of that is earmarked for adult social care and PPE. In addition to that, more recently, we've had, as I referenced, the returns that you've seen there in terms of the care home support plan. We've had some specific funding, a further 600 million nationally that is allocated with some very specific strings, but 75% of that is allocated to care homes now on the basis of their registered CQC beds. So they will effectively get just under £1,000 per bed for infection control over the next few weeks. We, as you know, have increased care home fees from the beginning of April to now the end of June by an additional £100 per week, which actually is in excess of the 10% sort of broad guidance. And for domiciliary care, we've increased hourly rates by £1 as well for that period. By £1 for that period. So we have done that. The CCG has also received some 1.3 billion to national to support hospital discharge arrangements, and in that context, there has been a pickup of a range of care packages in that, and that the future resolution of how that's going to be divvied out actually does encourage further partnership working in terms of, in effect, it will be a pooled budget, and what costs that we would have incurred in the past, we will contribute to the net cost to the CCG. I think that we remain awaiting further guidance with regards to how long will that existing funding announced provide for the care sector. Clearly, for homes that don't use a lot of local authority funded placements. The only pot of money has been the recent infection money that they will have utilised an awful lot. Okay. So we recognise that some providers, certainly I'm in dialogue with a couple that are particularly hard hit at the moment, and with the residue of that infection control money and the residue of resources in that very under pressure pot of generic money for the crisis, we will need to consider how we support and intervene where appropriate in the sector. What's quickly emerging as well, though, is that we need to ensure that that intervention is justifiable in terms of long-term provision, and that's a little bit of a crystal ball still at the moment in terms of what that provision is. As you know, we were very concerned around the future supply position, and we'll need to reflect on how that's changed. Has there been a shift to more community provision? And that is a challenge in itself, because clearly the boost to the domiciliary care workforce at the moment, will that continue when the schools reopen? Will that continue when leisure facilities start to open again and employment returns? We'll have to wait and see on some of those issues.
Brilliant, thank you so much. And is there anything that this panel can do to help influence that, especially for domiciliary care and private care funding? Or is it basically wait for the crystal ball to appear?
I think obviously we would be keen to see that adult care gets its fair funding through the generic pots, but outside of that, I think it is wait for the crystal ball before we commit to where, well, in effect, is state aid, where that intervention takes place.
Thank you very much.
Thank you very much, Leo. Can you remind me? It was Mike Solomon next, and then Councillor Gibbons. Is that right?
That's right. You might also want to check with our telephone councillors.
Ros and Ruth?
No, don't have anything at this point.
Yes.
Ruth?
No, I'm okay at the moment, thank you.
That's great. Thank you very much. We'll go to Mike Solomons then, please.
Good afternoon, Gerald. And let me say first off that I think you and your team are doing a first-class job, working very hard under these extremely difficult circumstances to look after vulnerable people, and well done. Second question I have is that this increased funding, the £1,000 per bed plus other fundings, well needed, I believe, and I'm hearing now from nursing homes and care homes that they're having to bring in a lot of agency staff, which is pushing their payroll up and maybe hitting them a little bit. What I'd be very keen to know in the future is that some form of scrutiny on the funds that have been paid into these care homes, that it's going to the right places, that the money is being used where it's being designed to be used, and not being used elsewhere.
Okay, the infection control grant is one of the most prescribed grants we've come across. So in receipt of their £1,000, they will actually have to consent to an agreement around how that funding is deployed. It's not historic funding, so it can't cover their previous PPE costs, which might not go down too well with some of the homes when they see the detail. So it is for the next foreseeable few weeks of the crisis. And outside of that, yes, it is very specific. The funding that we've already allocated, I think, is fair. I think in terms of the any further interventions that we need to support providers, we will need to consider the fact that, as per the guidance from the government, we have supported those services that have a high dependency on local authority funded cases. That's less supportive for those that have a higher self-funded base. and we will need to think about how we support those homes in particular that are picking up high staffing costs and high PPE costs. We do need to be careful, and part of the prescriptive guidance is, as I'm sure if my public health colleagues are still on the line or not, and I'm sure, is that obviously the use of agency staff needs to be controlled, because you can't use agency staff across services, and that may well have influenced, how homes have been affected by the crisis. So part of the funding, one of the illegitimate bits of the funding, is to ensure that agency staff are curtailed, that they're utilising their existing staff, and sometimes that they're supporting their current staff to sleep over in the service and avoid infection and etc. So it is very specific how that funding is, and some of that is detailed in that action, the Care Home Support Action Plan that you've got a copy of the draft.
Thanks very much, Sheldon, and again my heartfelt thanks for all the hard work you and your teams are doing.
Thank you.
Certainly all echo that, Mike, thank you. And Catherine next, please.
Thank you, Chairman. Yeah, I just wanted to echo what Councillor Solomon has said. You took the words out of my mouth in terms of thanks to you all for your hard work. And I have a slight confession in that I had to duck out for 10 minutes for another call. So if my question has already been covered by something else, just tell me to go away and shut up.
No worries.
I wanted to ask about tech and the things like the Amazon Echoes that might be rolled out, and Councillor Solomon will know that we're working a lot with mutual aid groups across the district, and I'm very aware that quite a number of isolated vulnerable people have been identified through this pandemic that we possibly didn't know about before, for whom such tech might be very valuable. So I'm asking, what's the capacity that North Somerset has to be supplying this kind of equipment to the additional numbers of people that might actually benefit from it out in the community?
So I think, as you're probably aware, and some members will have attended the workshop at Sycamore in Nailsea, that we are to some extent a national leader in terms of our use of tech. Clearly, funding is we've tended to fund it through different grants that we've been successfully awarded rather than have a pot of money. So resources are limited, but again, the NHS has funded through the winter funding extensions the work that we're doing via the well-being by the wellness service. I can say that we were just as COVID hit, and you'll explain that the care homes obviously went into they closed the doors. We were about to commit to some substantial cabling work to implement at scale acoustic monitoring, which some of you will have seen demonstrated at Sycamore. I'm pleased to say that we're waiting for the outcome of match funding from the NHS and NHS Digital to extend that further, so that in effect we would hope, when we are in a position where the care homes might open their doors to us, to allow that cabling to go in, probably, if we're successful, a third of the bed stock in North Somerset will have access to acoustic monitoring. Now, the benefit to that, not only I think is, there's a huge benefit to that, and just thinking about it, had that been in place for COVID, the early identification that could have happened around respiratory conditions, etc. But equally, it does mean that if we have that level of implementation in North Somerset, we would be able to, and we're at advanced stages on this, implement a centralised control service which would monitor the service. So the response would be at the home, but you'd have a centralised monitoring service all in one place for as many homes as we could support. The beauty of that is that potentially you could then outreach from those care homes to support community provision. And in theory, you could do that for both adults and children.
Okay, amazing.
In that sense. So I think we will be the first in Britain anyway to take, if you like, a commissioned approach to acoustic monitoring. And NHS Digital are very interested in our proposal, and I think the CCG is, well, I won't tempt fate. We're hopeful that some COVID funding will be released to support that soon.
Okay, thank you very much. That's really encouraging. Thank you.
Thank you, Catherine. Thank you very much for that, Gerald. How are we looking on the chat list questions list, Leo?
Yep, there are no further questions.
That's fine. Thank you very much. Thanks again for that, Gerald. Much appreciated. And thank you to all our presenters, if I may take the opportunity, please. Your time and your efforts are very much appreciated. I don't know if anyone else wanted to come in as any particular last minute questions to any of them, or whether we're all set to move on to just the final item, the work plan.
No, none.
We'll move on to item 7 then, shall we? Thank you very much to you all again. So obviously this is the final item. We've got the pre-COVID plan. Effectively, things have changed a lot since that was drawn up, and we amended it as we went forward during the end of last year. So this obviously needs reviewing and updating. We've got a very different and evolving landscape now, as obviously you'll appreciate. So we probably don't really need to go into much detailed discussion right now. We've had a long session, but we probably need to focus on one or two of those items that are in that work plan, and obviously look at the short and medium term priorities, what we should sort of bring forward, where we need working parties. Obviously things have been sort of blown off course with Healthy Western and obviously with the pandemic, so that's really kind of taking the headlines. But I don't know if you want to come.
May I ask what happens to the quality accounts? Is everybody's being cancelled so as they don't have to do them? Because we were due to meet on the 3rd of April or whatever.
Yeah, better at that one, Leo. That's kind of where we were at, wasn't it?
Yeah, there's been discussion at the NSSG level amongst the other HOSCs about this issue. Some of the providers are going ahead with their quality accounts. Some have extended the timescales by which they will provide them, and one in particular will not be providing one this year. The one we understand that won't be providing one this year is our community health provider. I understand there has been this has been permitted at higher levels. So that's the situation. When we do get the quality accounts across my desk, the approach that we've agreed across all, well, certainly with the chairman's agreement, has been that instead of trying to deal with this as a subcommittee of the panel, that we will go back to the approach taken prior to the formation of the subcommittee, in that we will circulate them to members for comments, and we will also try and coordinate those comments across the three different HOSCs, so that where possible we can provide one response to the provider.
Okay, thank you. I was just wondering whether, they may well have, been rolled over the same as everything else is rolled over and not done this year, because things are exceptionally different, and for trusts and partners to find the time to actually have to do this, I think is not good enough. I think they should have been given chance to have rolled it over and not done it this year for them. It's not fair. Not fair on them. That's my view anyway, Chairman.
My understanding, Chairman, is that the department, I think it's the Department for Health is being flexible about this, hence the fact that some of them are going with an extended timescale and will be doing them later in the year. I think there are one or two that felt that it would be better if they could to meet the existing timescales, if at all possible, simply because some of the work had been done and it made sense to get it out of the way if they could, rather than hampering them later on down the line. So it's a mixed bag. We will be getting some shortly, and others will happen further on down the track.
Thank you, Chairman. I wonder if it would be possible, if the panel agreed, that we could, and I don't know whether our exec member is still on, Councillor Bell, but if we could write to our exec member to say, that I am concerned that trusts and partners are having to do these quality accounts at such a time of national crisis, and that it's extremely unfair on them to have to do this. I mean, for us as panels to try and do it virtually is a nonsense, but goodness, we're not coping with what some of these people are coping with, and I just think it's extremely unfair, and I'm wondering if we could write and ask them to pass it on to the DOH or something. I don't know how everyone else feels.
I'd certainly be happy to go along with that suggestion, Ros. And any other views on that? It seems certainly to make sense to me, and it's a tough enough job, I gather, from previous years. I obviously wasn't on the panel before, but I gather it's a bit of a slog just in a normal time.
Yeah.
Any other views at all?
Chairman, I have a request to speak from Councillor James.
Certainly. Come on in, Hugh.
Yeah, that's differently from this. It was just under 1B. Obviously, Robert Walker from University Hospitals Bristol and Western just agreed to come for an inquiry day to HOSP when the incident investigation is over. So I thought we'd just put that on the work plan to make sure it's followed up.
Okay, thank you.
Brilliant.
So is that okay?
Absolutely agreed.
That recorded, Leo. Thank you.
Yes, we will make sure that's very high up in the priorities on the work plan.
Brilliant.
Is Mike still on then, our executive member, in terms of Ros's suggestion? Any comment on that, Mike? He's gone. Is he still on there?
Yes, I can't see Mike. No, he's not still on the list of attendees.
No trouble. We'll take that as read from our panel that we'll go ahead and send that letter. Okay. Yeah. Any more comments on the work plan at all?
Yeah. I just wanted to say there, it's Jeff Richardson. I'm quite happy with that suggestion from Ros, and I think it's very reasonable. But I think we need to replace it by asking those people who would have produced those plans to come to the panel and speak to us instead.
We can set up some virtual meetings, or
either informally or formally. I don't mind really, but we need to be kept up with what they're up to.
Yeah. So that's sound feasible, Leo?
Yes, that sounds very feasible. I mean, we should be regularly hearing from our providers with performance reports. So it makes sense to do that. It is. It may be something that we could do informally or formally. I'll leave it to yourselves as members to for your views on that.
Okay, there's quite a few things that we can discuss sort of online and email between each other, I think, aren't there? Okay. Anything else work plan wise from anyone? I think we're all ready to close the meeting by the sound of it, aren't we? I think we've had a very good, productive session. Thanks to all the presenters, a lot of information, very difficult times, and thank you all for your participation this afternoon. Much appreciated.
Thank you very much, Richard. Very good. Thank you.
Thank you.
Well done, everyone.
Yes, absolutely.
We were wondering how it was going to go.
Thank you very much, Chair.
We got through all right. Thank you all.
Thank you.
Thank you.
We'll catch up soon. Cheers.